Uh, I'm Jyoti Marvin. I'm the director of the Joint Medical Program. I'm so proud. What an awesome day. I just have such a warm feeling in my heart. It's so incredible to see each one of you doing your presentations, hearing about your amazing work, and Leanna and I were reflecting on, we see you doing clinical skills, we see you doing PBL, and then to know that you're doing all this incredible research, and then to see you present it is just like mind-blowing. We're so in awe of each one of you. So congratulations. I'm so excited for you. And also I have to say, I'm like starting to sink in that you're going to be leaving us soon and moving across the bridge, which makes me sad, and happy to know that I will hopefully see some of you at San Francisco General Hospital. It is my great pleasure to open up our second half of Symposium, so opening up our afternoon session. And who better to get us started than Dr. Peter Chin Hong, who has just been a wonderful friend to the JMP. All of you know him well, so without further ado, Peter, come join us.
Hello, everybody. This is going to be very short because I don't want to disrupt the schedule, the tight schedule. I have just a few, three things to say. Number one, I'm like super excited to be here. I'm always feel so peaceful when I come over here, and my only regret for today is that I can't go to VIX with Jyoti and Liana, because that's kind of like a tradition when we kind of talk about lots of stuff. And Shalene was in Nashville with me for the double AMC conference, and I asked her, we were talking about the food that we ate in Nashville, and Shalene actually, and you can talk to her about this, actually went to a combination beer pub and chat place, which was kind of cool. But she looked kind of snobby because I think the intuition, she intimated that VIX was still far superior to chat in Nashville. The second point is that, I'm so psyched and always feel so proud of your accomplishments, even just listening to some of the talks today and hearing about them all the time from the JMP leadership, all the projects you're doing, talking to Coco and Amin and many others about all the work that you've been doing. It's such high quality, and I feel so proud. In fact, again, coming back to the WMC conference in Nashville, many of the hot topics in American medicine, American medical education today are all the things that you are talking about right now. And it hasn't always been the case, but right now it is the moment. So seize the moment. I'm also excited about your transition. So, I always reflect on my own transition when I went to the clerkships from sort of like the protective cocoon of the first part of medical school. And it was really exciting to me, even though, I felt like I didn't have exactly all the knowledge. But as long as you keep your mind open, I think particularly for all of you, it will be so exciting because you'll be interacting with humans as patients, and that's when you're going to really learn the medicine, and the words will come alive, or the pictures, or the apps, whatever you use these days in your generation. And the third thing I want to say is that I represent not just myself and my weirdness and quirkiness, but also the rest of the deans at UCSF School of Medicine, where I continue to represent JMP at the table. And I will continue to do that. And as long as you're there at Parnassus, it was hard until this point because of COVID restrictions. I couldn't really have that fridge that I was dreaming of, full of like liqueur and Diet Coke, whatever JMP students like to drink. But at some point, I'm going to set it up, and I'm going to, you can all come and like get not just like a lukewarm beverage that you have on the shelf. Although in San Francisco it's really cold, so it's often very like a fridge anyway. But you can also have it from a real fridge in my office. So thanks very much for all that you do, and it really, really is joyful for me to be here. I'm supposed to introduce Vishali, since she introduced me at the JMP fundraising event, and we thought it would be kind of cute to do so. And so Vishali Lumba is going to give you the next talk, which I'm excited to hear as well. And I want to give a shout out to that, Vishal Lumba. And, thank you for all that you do. Well, sorry about that. Justin, I didn't mean to steal your thunder.
What better person would get 2 introductions? So yes, I would love to introduce you to our next presenter, Vishali Lumba. Her hometown is Antioch, the Yock for those that are in the Bay. For undergrad, she went to UC Berkeley, and I just want to share a tiny fun fact. She served as Berkeley student body president. Prior to the JMP, she worked at Women's HIV Clinic, researching trauma-informed care, and worked for California on studying how to screen and respond to ACEs in California's pediatric Medicaid population. She's really interested in the field of social care and the impacts of trauma and social and structural determinants of health, and she is even more interested in what the healthcare system can do to address trauma and social risks, to improve health, provide whole person care, and improve health equity. She's also interested in how to change our models of healthcare to better serve patients. Her research is focused on screening for social risk as a healthcare intervention and whether this is the right approach and what will best serve patients. Aside from being the de facto Gen Z whisperer for millennials in our class, what I particularly admire about Vishali is her commitment to health equity. In class, she brings forth ethical frameworks to evaluate various decisions of care for the patients in our educational cases. As a future physician leader, I have no doubt that Vishali will strive to ensure the best care for actual patients and advocate in the level of leadership and policy to ensure all patients receive the quality of care they deserve. So without further ado, again, I'd like to introduce Vishali Lumba.
Oh man, thank you both for those really wonderful introductions, so kind. So I'm going to talk a little bit about my research on the ethics of social risk screening in healthcare. Before I get started, like many of my classmates have done before me, I just want to recognize the ongoing strike. I do feel a little bit of cognitive dissonance recognizing it while being here, but it's something that we can all be supportive of in different ways. And so I urge you, if you haven't already, you can sign up to join picket lines, donate to the Workers' Support Fund, or sign the Solidarity Letter, or visit that website for more information. I hope we're all able to do something. Okay, so for today, for my research, I'm going to give you a brief overview of the research that I worked on for the last 2.5 years while I was at the JMP. I really want to spend most of my time today emphasizing why I think this work is so important and timely, and what we can do to continue to build on this work as social care expands in healthcare. So to start out, what are we even talking about when we say social risk screening? Luckily, Justin went before me and he explained this to you really well, so I don't have to reemphasize all the points, but for this discussion today, I'm defining social determinants of health as just the top of this image. They're the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of our daily life. Social risks are the downstream adverse social conditions associated with poor health. So that's what we're talking about today, those social risks. And they include things like food and housing insecurity and many of the things that Justin mentioned. So our project looks specifically at how healthcare organizations, which are typically at the very bottom, just responding to the negative consequences of social risks, are attempting to intervene slightly more upstream on social risks, and importantly, the ethics of healthcare organizations getting involved with social risk screening and response. So why is looking at screening for social risk healthcare interesting? Well, treating upstream social risk is really powerful, and it gives us the opportunity to improve health outcomes in a meaningful way. And this is being recognized by many different organizations and regulatory bodies. we're in the middle of a national conversation about what the healthcare system's role and responsibilities are with regards to social risks. And there's many large policies that are being debated regarding all aspects of screening, including things like different approaches to screening, who we should be screening, which patients should be screened and what they should be screened for, and how the healthcare system should actually respond to identified social risks. Additionally, many organizations are already implementing social risk screening in some form, as Justin mentioned, and there's a large chance that this will continue to grow, and there might be we might have mandates for all healthcare providers in the near future, or increased financial incentives to provide social risk screening. So long story short, this is a relatively new innovation that's rapidly spreading nationally, and it can have major impacts on healthcare spending, healthcare services, and health outcomes. So you may be thinking, well, that's all great, but healthcare has new innovations and interventions all the time. Why are the ethics of social risk screening any different than biomedical ethics that we already use for other decisions in healthcare? Well, although there are traditional bioethics, one of these things is not like the other. Social care is different from traditional healthcare. Social risk screening programs are different because parts of social care are outside of the walls of the healthcare delivery sector. Social care has also traditionally not been funded by healthcare sources, and social risk screening and addressing social needs is not something that healthcare providers are trained to do, nor have they had the resources to address social risks in the past. So there are many big questions as to whether this healthcare system has a role and what exactly that role and responsibility should be. This is a complicated question for a number of reasons. We know social risk and social determinants impact health, and addressing social risk has the promise of improving health outcomes. And we also know that social risk screening is being championed as one component of multidimensional efforts to improve health equity. There's many stakeholders that are involved with social care, and much of the response is outside of the healthcare system. And then in addition, many questions remain regarding the implementation, including who should pay for it. So in order to answer this complex question, it seems imperative that we understand what the moral and ethical obligations of the healthcare system are. So for our study, that's what we did. We wanted to look at what the main ethical concerns around social risk screening are. And in order to do that, we talked to the stakeholders who are involved in screening in order to understand what their concerns were, as well as the underlying ethical values that guided them. And then we wanted to look at the ethical values espoused by stakeholder groups and link those to existing ethical theories in order to identify a guiding framework that we can use to make decisions regarding social care integration in healthcare. So the theoretical framework we used for this study was derived from 3 normative theories that influence applied ethical reasoning: deontology, utilitarianism, and virtue ethics. I'm not going to go into the specifics of the ethical theories here because of time, but for our purposes today, we started with the applications or decisions that go into social care and what those decisions are based on. So basically what we wanted to know are what are the concerns and decisions being made regarding social risk screening. For example, if we look at one possible implementation decision, like embedding a social risk screening tool into the health record or not including any social risk data in the health record. This is a very standard decision that's being made. Then we would look at what are the underlying ethical values driving either decision. So following the same example, the ethical value driving the decision to put screening tools and the screening data into the EHR would be maximizing best outcomes, making sure screening data is easily accessible for providers. Whereas the value underlying a decision to limit social risk data and not include it in the EHR would be valuing patient empowerment and respecting informed consent. And then from there, we'd go one step further and really look at where the unifying ethical framework or theory that's guiding those decisions and values. So in this same example, we'd say the normative ethical theory for maximizing best outcomes is utilitarianism, while the theory for patient empowerment and informed consent is deontological. So again, that's way too detailed for this talk, and I won't go into any more of the actual ethical theories for today. But the main takeaway from this is that all of our decisions are value-laden. So it's really helpful for us to understand what values are guiding our decisions to ensure that we're acting ethically and in the best interest of patients. So this study was part of a larger Robert Wood Johnson funded SCREEN study that focused on social screening in healthcare settings. When I joined the team, the research team had already conducted one set of focus groups with stakeholders for this amazing literature review that was put together regarding all the big questions around social risk screening. And then when I joined, we designed a second round of focus groups with the same stakeholder groups to specifically explore the ethics of social risk screening. So we asked the key stakeholders who were involved, and who are the key stakeholders for social risk screening in healthcare. Traditionally, the stakeholders involved in most healthcare innovations are healthcare providers, policymakers, and health insurance payers. And increasingly, patients are being recognized and included in these conversations. For our purposes for social risk screening, we have one additional stakeholder, community-based organizations, who are the lead on the actual provision of social care to respond and address social needs. So for this research project, we conducted 90-minute focus groups with a national sample of these stakeholders to understand their view of the duty of the healthcare system in social care, their concerns regarding social risk screening, and their perspective on the rationales for screening within healthcare. We then coded these stakeholder focus groups using these 5 ethical values that are derived from the theories I mentioned previously, as well as from the actual content of the focus groups. So the values we defined are slightly different from how they're traditionally defined under normative ethical frameworks, which are responsive to what our stakeholders told us. The values we included are beneficence and provider duty to the patient, maximizing best outcomes, patient empowerment to respect a person's right to self-determination, equity and resource allocation or distributive justice, and acting with integrity. So what did we find? Well, what we found is there is really no unifying ethical framework, and that played out in many ways in our groups, 3 of which I'll talk about today. We found that stakeholder groups who differed in their perceived ethical and financial responsibilities view social screening and social care through distinct moral lenses. We also found specific ethical concerns regarding the impact of adjusting medical treatment based on social risks. And we found that stakeholders had many concerns that highlight the ethical ambiguity around responsible data stewardship. So first example, is there a tension between ethical and financial obligations? This example came through in concerns that providers have regarding their own duty towards patients to do no harm and whether that encompasses addressing social risks versus healthcare payers who have reasonable concerns regarding their duty to the actual payers of health provisions of healthcare. So in this specific example, I think this example is an example of a core ethical conflict facing social care delivery that involves the scope of ethical obligations of healthcare providers versus the financial obligations of payers in our American system. And this issue really isn't new. The US healthcare system has long struggled to straddle the competing obligations to respect and improve each patient's health versus the reality of being a profit-driven incentive system. So in this context, in the face of very compelling data that social risks do influence health outcomes, this conflict's made really obvious because paying for social services as essential health services could threaten the financial viability of the healthcare system. So in our American context, it then becomes immediately critical when designing social care to clearly define which services to pay for and for which populations. Payers, those who front the cost of administering healthcare, maintain that healthcare systems need to maximize positive outcomes per dollar spent. So in this quote, it describes how payers do not want to have to address housing insecurity because they see this as an overload, which could conflict with creating best outcomes in the sense of maximally efficient dollars spent. Providers, however, framed their decision-making around their perceived sense of duty to patients to do no harm and felt that social risk should be addressed as part of healthcare. These prevailing values can be at odds here in that the healthcare system is incentivized to maximize its profits, but its stated goals often center on high-quality individual patient care. Another example, an important finding from the study, was regarding medical treatment adjustment, something that's talked about a lot when we talk about collecting data on social risks. Despite a growing interest in personalized precision medicine, Many of our focus group participants were very concerned that providers might use social risk data to change care without meaningful shared decision-making, and they worried that this could cause patients with more social risks to receive substandard care. There are currently no standards or training for if and how medical providers should adjust treatment based on social risk effectively and without bias. But other participants also recognize the downside of not considering social risk, which can make medical treatments less accessible. In our groups, patient advocates desired personalized care, and providers argued strongly that not adjusting medical treatment based on social risk information was what meant providing substandard care. And finally, in the third example, stakeholders identified many concerns regarding ethical data stewardship and underscored the ambiguity specific to social care. Many data stewardship concerns related to social risk data protection, access, and sharing that were raised throughout all stakeholder groups. And one of the largest tensions that emerged was about data ownership, where ambiguity surfaced about whether healthcare organizations, health insurance payers, or patients themselves own their social risk data. This is really important given there's a financial incentive for health insurance payers and healthcare organizations to own social risk data. And patient advocate participants we spoke with felt strongly that given the stigmatizing nature of social risk information, the potential nefarious uses of this data in the wrong hands, and how dynamic the information collected is, patients should have control over what's on their record, who has access to it, and be able to change and update their information when needed. So our results lead us to an important question: whose ethical values matter? We found that stakeholders had many different areas of concern, and even when there was apparent alignment of concern, the ethical basis for that concern differs. The reason that these differences in values matter is that it means there's no one unifying ethical value that can be used to guide decision-making regarding social risk screening. And this means that no one stakeholder group can reasonably be making these decisions. Based on our findings, we know there's no framework, and we also know that we need a unifying ethical framework to guide national policy. In order to get there, we need to engage stakeholders and ethicists on defining a roadmap for ethical decision-making in social care. And in order to do that, there's some fundamental questions we still need to answer. Is there a group of stakeholders we need to prioritize in defining the ethical framework on national policy? And in defining these stakeholder groups and determining who is at the table, how can we apply an anti-racist lens to ensure marginalized voices and those most impacted are represented in these decisions and the development of guidelines? Hopefully, once this paper is published, I'll continue working with my research mentors on this next phase of developing a guiding ethical framework for social risk screening in healthcare. And speaking of my mentors, I would love to thank so many people who helped and guided me every step of the way on this project. It really does take a village, and I absolutely could not have done it without the amazing support and mentorship. So many. First, I'd like to thank Dr. Laura Gottlieb. She is absolutely phenomenal, and it was such an honor and a privilege to get to work with her. I learned so much from her. She's a brilliant mind, an innovative leader in this field, and also just an incredibly supportive mentor who stuck with me through so many revisions of this paper and these ideas, and I'm so grateful to her. I'd also like to thank Dr. Jody Halpern, who I know is watching, who's my second thesis mentor. She's a brilliant ethicist who teaches me more about ethical theories every time I speak with her, and I'm so grateful for her mentorship on this project. I encourage all the JMP 1s and 2s, if you haven't, to take her class on ethics. It really influenced my time here. I'd also like to thank briefly the screen study team that worked with me on this project. They were amazing mentors as well and helped me every step of the way, including getting my ROB on time for Gustavo. I'd also like to thank my JMP mentors. I'd like to thank all of the JMP faculty, but all of these mentors actually helped me specifically with this project. I'm really grateful to you. I'd also like to thank the Prime faculty who've been so supportive of me in the last 2.5 years. And I could not have made it this far without each and every one of them. And I'd like to thank my family, my JMP family, and my actual family, my parents and brother. My dad actually texted me at 12:45 to remind me that my presentation was at 1 o'clock. I really can't do it without their support. every step of the way, and I'm so grateful for them. And finally, last but certainly not least, I would really like to thank my husband, who was just my boyfriend when I started this program, and somehow supported me. I could not be here and do every day without his love and support, and still decided to marry me. So thank you. Thank you very much. Thank you.
We have time for one question.
Thank you so much. That was such an interesting presentation. I'm curious about the stakeholder recruitment process. Can you tell me a little bit more about how you were able to get access to all these perspectives?
Yeah, so the question was about how we recruited stakeholder participants for the focus groups. That is a really good question. Just go right back to my amazing mentor, Dr. Laura Gottlieb, because it was really because of her and the Siren Network. It was a snowballing strategy, but basically they work with a lot of national leaders who are representative of these different stakeholder groups, and they recruited through that sample of people they knew, who then recruited from their friends, and we were able to get people from all over the country to participate. Okay, I have the distinct honor and privilege of introducing my classmate and friend and someone I admire very much, Caroline Mattinger. Caroline was born and raised here in the Bay Area in the Castro in San Francisco. She has a humanities background, meaning she somehow mastered both humanities and the sciences. She majored in both English and Spanish at Mount Holyoke College in Massachusetts, and she had an entire career in publishing in New York City before a life-changing experience led her to medicine. Her ability to understand so many diverse fields comes from her empathic curiosity. I'm sure all of our classmates would agree, Caroline has been the grounding presence of our class. She somehow is a phenomenally bright student, helpful classmate, generous friend, while also being a loving wife, daughter, and the best mom to our class baby, Archie. She's also a passionate thought leader in palliative care. Her ability to do so much with such focused intentionality is inspiring to all of us. Her research is an extension of this. She decided on her research project because of an article we read in Professor Obisogi's class our very first semester at the JMP about racism and end-of-life care during the COVID-19 pandemic, recognizing that so little research has been done to address inequality in palliative care. She spent the last 2.5 years dedicated to expanding research in this area with her thesis project. So please join me in welcoming the amazing Caroline.
My partner this morning about presenting, and he asked me who I was presenting after, and I said Vishali, and he said nobody deserves that. I will go ahead anyway. Thank you. So before I begin, I want to acknowledge this is a quantitative project, but it is about something that touches everyone's lives. End-of-life care is a type of care that has really rich and oftentimes really difficult experiences. And I want to acknowledge that everyone in this room probably carries some story with them. And if you need to take care of yourself as you engage with this presentation, please do. So thank you so much, Vishali, for that wonderful introduction. It was so kind. It gives me great pleasure to present this project today, Racial and Other Inequities in Palliative Care Receipt. And I want to start by just giving a big thanks to my mentors over at UCSF in the Division of Palliative Medicine. Dr. Mike Rabo, who's not here today, and Dr. Dave O'Riordan were instrumental in this project, and I couldn't have done it without them. So I want to begin and describe my motivation for doing this project. As Vishali mentioned, in our first year here at the JMP, Professor Obasogi assigned an article, and it was called Sent Home to Die. And it described 25 Black patients who went to the hospital during the height of the COVID-19 pandemic seeking healthcare. And they were denied healthcare at the time, and they were, in an egregious act of racism, sent home with a referral to hospice. So this question for me raised really serious concerns about how end-of-life care is being implemented in communities of color. And this project builds on a small but very essential body of literature just starting to define inequities in end-of-life care as a step in rebuilding this model to be more equitable. So I want to begin just by defining what end-of-life care is. It's an ambiguous term. There are two major branches, but the overall principle is addressing symptoms and improving quality of life for patients who have serious illness. So hospice is what's most commonly known, and that's something that you're eligible to receive in the last 6 months of life. And in order to be eligible, you have to stop receiving any curative treatments. Palliative care offers very similar services, but you can receive it at any point in your serious illness trajectory, and you can continue to receive treatment. So there are some differences in the impact of accepting these types of care. All of that being said, both of these are fundamentally designed in the setting of patients who are receiving aggressive treatments at the end of life. So this model is really developed for the typical white patient who has abundant access to care. And a lot of questions remain about how applicable this model is and how it's benefiting communities of color. So that's where I just want to begin to define what are the inequities in this field that we know about so far. And so we have abundant research about inequities that occur in cancer care. We know about low screening rates, late diagnoses, and barriers to care. We know a lot less about inequities in end-of-life care. And common wisdom will tell you that Black and Hispanic patients are underutilizing palliative care, and that has driven research around patient mistrust of the medical system as a main driver of this fact. However, there is not a lot of research backing up that theory, and the literature that does exist that describes who's using palliative care is very mixed. So that leads us to our decision to pursue this question. We really wanted to know, to get an overall sense of who's receiving palliative care and what the reasons physicians had for making these referrals, and what the timing was like in the disease course when they made these referrals. So in order to do this, we accessed a large cancer registry in an academic medical center and collected over 10 years of patient data of cancer patients who died in this cancer center. And then we matched it to the palliative care database in the same institution. And this way we could identify a huge group of potentially eligible patients and identify who can refer to palliative care. And we made comparisons between these groups. We had a lot of demographic data. And then we also looked among the palliative care recipients at the characteristics of the referrals that they received to get a little bit more of a sense of why and how they were referred to palliative care. So our overall sample population included 18,797 patients, but just 7.9% received palliative care. And this is a summary of the majority of the patients that we saw. As you can see, they were majority white, and in the next slide, you can see just what a majority that is. And this is not representative of the racial composition of the city, but this is an example of the institution. And then you'll see that the next largest group was Asian patients at 14.5%, and then Latino patients and Black patients. And this is another summary of our sample population. We can see that a large majority, about 80% of our patients had either Medicare or private insurance, and just 20% had either Medicaid or another form of insurance. So when we performed an analysis, we first looked at who received palliative care. I want to draw your attention to the red box that you can see in the first two lines. You can see the rates of receipt of palliative care for Black and Hispanic or Latinx patients. You can see that there's no significant difference in the receipt of palliative care for these populations. In the third line, surprisingly, you can see that Asian patients were receiving palliative care at 42% more rate. And then when we looked at insurance, we found other significant findings. If you look at the red box, again, here you can see that patients who had Medicaid or another form of insurance were much less likely to receive palliative care. Medicaid patients were 26% less likely, and other forms of insurance were even worse predictors of palliative care receipt. So here's a summary of the other findings of positive and negative predictors of palliative care. And I just want to summarize what we found so far with this analysis. So first, this was a big contradiction of the common wisdom. This represents a single institution, but we didn't find any evidence of underutilization, which is a pervasive narrative in the field of disparities research. It's possible that there's variation between institutions. Palliative care does not have a standardized referral process. And another consideration is whether mistrust and preferences for aggressive treatment at the end of life have been overrepresented in the literature. The second component that we found were that there are structural barriers to palliative care. Medicaid and other insurance types were very associated with not being able to access palliative care. And what we can infer from that is that because of structural racism, patients who are Black and brown are much more likely to have these insurance types. So while we're not finding evidence of underutilization, we are finding a high likelihood that these patients are finding barriers to accessing care. And then the last finding was really surprising. And part of the reason this was surprising, that Asian patients were so highly represented in the palliative care population, is that they haven't been studied in disparities research in palliative care. So this was a surprising finding for us, and just doing this simple quantitative study does not explain why. But we did continue to interrogate referral processes, so we can dive in a little bit more. So we looked at reasons that physicians made these referrals into palliative care. And we looked and found results in patients who were referred due to pain symptoms. So when we first looked, we didn't find any significant differences because we were looking at age, insurance, and race. And we recognized that insurance and race had a lot of correlation. So we weren't actually able to appreciate the relationship between race and the outcome of referrals for pain symptoms. So this is a little bit of a technical description of what we did methodologically, but we removed insurance so that we could understand better how race and this outcome were relating. And what we found was that Black patients were much more likely to be referred for pain symptoms. So what are the implications of this? So this is just one piece of evidence, but it does suggest that patients might not be receiving different rates of referral, but they might be referred for different reasons. And what does that tell us? We don't know from this study. We can make conjectures, and one conjecture that we thought of was pain management upstream. So if patients are not, if their pain isn't being managed by oncologists, or oncologists are reluctant to prescribe medications, as we know in literature happens frequently for Black patients, these providers might be using palliative care as a third party to offload that responsibility. So there are implications upstream and then also implications downstream for how this is actually impacting pain management for these patients. The next area that we looked into was the timing of palliative care referral. And we looked at this in two ways. One was looking at the overall health of patients when they were referred to palliative care. And we found that Asian patients, compared to all other patients, were a little bit sicker. And this was significant, but only a slight difference. In our next study of the timing of referral, we looked at the survival period after referrals were made. And here we found that Asian patients had significantly less time from palliative care referral to death compared to white patients. So what can we make of this finding? This was a little bit puzzling for us. On one hand, we're seeing high rates of referral for Asian patients into palliative care, but we're also seeing that these referrals are coming later. So it seems like more care and less care. One possibility is that these patients are experiencing barriers to care, so that when they are receiving these referrals, they're coming later and their needs are more complex and they're more likely to need other services. So there's one indication for looking upstream for drivers of this. Another important component is what we do know is that earlier referrals into palliative care are highly correlated with more benefit from the actual intervention. So if we're seeing these delayed referrals among this population, it's highly likely that they're not receiving as much benefit as white patients from the referral process. So this is an area that is definitely in need of more research. So in summary, what did we learn? One, we learned that there's not evidence in this study of over-referral or underutilization of palliative care for Black and Latina patients. But our findings did suggest that there are possible structural barriers still at play, including insurance and also ways that palliative care is being used to intervene on symptom management. And lastly, our study contributed new research, a very poorly studied Asian population in end-of-life care, but has really brought up more questions than it's answered. And I just want to end by acknowledging that there are so many limitations to doing this type of research. One, in order to do an introductory analysis, we conflated a lot of racial and ethnic groups. So this is really important when we think about describing impacts on Asian communities. In San Francisco and in this study population, Chinese and Filipino patients were the two majority Asian populations, and it's likely that they're experiencing really different types of barriers. So future research should definitely look into disaggregating this data. And then secondly, this is a single institution and in a single region. As I mentioned before, palliative care is relatively new and the processes of referral are not standardized. So this means that there's a lot of room for bias and opportunity for racism to occur and manifest in different ways. So while we didn't find over referrals here into palliative care for Black patients, we know that it occurred in Louisiana in 2020. And then lastly, the diversity of the cohort was really limited. And so that just limits our ability to make generalizations about how palliative care is being distributed at large. So in light of these findings, I have a few recommendations. Healthcare policy, single payer healthcare would solve a lot of problems. We don't know exactly what the barriers are associated with Medicaid insurance, but talking anecdotally to a couple of people at UCSF, I know that the bureaucracy itself is burdensome and that differences between Medicare and Medicaid that just shouldn't exist are clearly having impacts on patient health. And then for future research, following up this qualitative research, we really need qualitative research to understand the why. Why are we seeing these differences in care, particularly for Asian patients? And What are the desires and goals for these patients? Is this high level of palliative care what patients are seeking? And lastly, testing interventions. Where would we be if we just left research with results? We need to find out what will actually make real impacts on people's lives. And that means identifying ways to identify patients early so that they can maximally benefit from care, and being consistent and equitable about how we identify patients for palliative care. And I want to give a big thanks again to my mentors at UCSF for their immense help, and also at UC Berkeley, and that goes from my direct help on the project and also all the faculty who've helped form my theories that I applied in this research, and then the JMP3s and my family and my baby for keeping me up last night. Other folks have mentioned this before, but if you need the QR code so that you can provide hands-on support for this strike, I'm going to do so later today, and I'm going to leave this up here so you can use the code.
Gregor, just one question for you. You talked before about the possibility that one thing that might be implicated for the Asian patients' use of palliative care might be language, and I wasn't sure if you had looked at language proficiency or match with provider, or like where the thought had, not just the thought, but like what information about preferred language had informed the thought that language might be a barrier.
That's a great question. So I'm going to repeat it in case the viewers didn't hear that. So on my slide, one of the conjectures about these disparities for Asian patients was language. So I think I just wrote language on the slide, and I wanted to clarify what that means, or what my thinking was. So we actually didn't collect any language data, but there have been other studies that have looked at limited English proficiency and associated it to actually higher rates of palliative care use. And that, I think, has to do with time constraints in oncology settings, and that palliative care is often a third-party service, and we don't know what the actual, or I don't know what the impact is, but that palliative care can be used to intervene and provide extra resources, and including translation services. So that was where my thinking was.
To keep us on track, if you continue.
Okay.
So,
Like that. Okay, one. So it gives me great pleasure to introduce our next speaker, Jessa Culver. So Jessa is from Paso Robles, California, aka The Ranch. She attended UCLA in undergrad, where she studied international development and public health, and she has a deep interest in community health. This brought her to East Palo Alto after graduating, where she worked at a preschool and elementary school in a minoritized community. She worked to facilitate communication between teachers, parents, and health team members to ensure children had their health, academic, and developmental needs met in a coordinated manner. And those experiences, working closely with kids and families at this school, inspired her project that she's presenting today. This project that focuses on access to early intervention services for children. And I want to say that over the past 2.5 years, I've witnessed Jessa's dedication to implementing anti-racist praxis in education beyond the scope of this project. And the research that she's presenting today reflects just a small part of her many efforts towards this end. And as a community member, Jessa has embodied the healer from inside and out with her reflectiveness, her tenacity, and her integrity, and her deep friendships that she has with each of us here. I want to take a moment to honor her and welcome her to follow up.
My name is Jessa, and the title of my presentation is Caregiver Experiences of Racialization While Accessing Early Intervention Services for Their Children. I just want to flag that this presentation includes depictions and direct quotes regarding racism. And before I get started, I also want to offer some definitions. I'm going to be using the term caregiver to mean the parent or legal guardian of a child. And because race is socially constructed and not biological, we use the terms racialization to describe the processes through which racial meaning is socially ascribed to people. And people aren't naturally minorities, but are actively minoritized by social structures. Yeah, hang out on this slide. So before starting med school, I worked at a preschool in East Palo Alto, where I saw how pivotal those early childhood years are in supporting children's development. I witnessed the power of early intervention services in supporting children to actually be able to access learning in the classroom. And this is me as a sink to promote hand washing. So the CDC defines early intervention as services and supports that are available to babies and young children with developmental delays and disabilities and their families. So this includes things like occupational therapy, physical therapy, speech therapy, etc., depending on the needs of that child and the family. And to get services, it is a process. So you start with screening, typically at the pediatrician's office, and then you're referred for evaluation where they assess eligibility, and then you eventually get the service itself. And this happens across 3 different systems. So I already talked about the pediatric health clinic, as well as regional centers, which are funded by the state. There's 21 of them across the state of California, and then the school system itself. So back at the school, I worked with minoritized families who are navigating this very complex process, oftentimes going through multiple systems. I witnessed the love and persistence that they had in advocating for their children, and also the barriers and the challenges that they faced. And as a med student, I hope to take this opportunity to more deeply understand the experiences of caregivers as they navigate this process and elevate their stories in order to improve access to these really pivotal services. I also want to take a moment to acknowledge my positionality to this work. Although I identify as a biracial person with experiences that have shaped my relationship to ableism, I'm not a caregiver of a child with developmental needs, and I also do not identify as neurodivergent. Okay, the context of this work is that there are significant racial disparities when it comes to early intervention access. And this happens from the point of screening to getting a referral to being evaluated to actually getting the services. Minoritized children are falling through the cracks. And this is just one statistic. So when I was looking at the literature on this topic, I found that there are structural factors to explain these disparities. So researchers talk about how lack of access to primary care and specialty care impacts access. There are language barriers, and the screening and assessment tools are falling short. I then looked at what other researchers found after interviewing caregivers themselves. And I found that these studies often used a deficit-based lens that situates race as a predisposing factor to be analyzed, rather than centering racism as a key driver. For example, these studies suggest that minoritized groups have different attitudes and beliefs that delay help seeking. They talk about how caregivers understand development differently, or how they're less likely to help seek outside of social circles, or that there's increased stigma around developmental diagnoses. And again, race is incorrectly used as a proxy for racism in these studies. We decided to use a critical race theory lens to pivot away from what are caregivers doing wrong or how are their attitudes different to how does the process of accessing early intervention services racialize the caregivers who are navigating it? And how do minoritized caregivers perceive racism as impacting their experience of the process? So for our methods, we advertised at pediatric clinics and early intervention organizations across the Bay Area using flyers, and we were able to recruit 9 caregivers who self-identified as minoritized and had sought early intervention services for their kids. And we conducted interviews with each participant over Zoom for an hour, and we did this twice. And then we analyzed interviews using qualitative content analysis. And we intentionally chose to do a second interview with each caregiver because we wanted to give participants more agency in the process of knowledge production. And this is an approach coined by Jen James at UCSF called Black Feminist Epistemological Methodology. And so how this worked is basically after the first interview, we wrote up a written summary of what we heard and then read that summary back to participants, giving them the space to validate, incorrect, or disagree or correct, and basically giving them space to interact with their own data and have a sense of how they'd be described in our writing. And these are some sample characteristics, just to show that across immigration status, insurance, child age, and diagnosis, there's a wide spectrum of representation. And now for results, I'm going to share across three themes that we eliminated. I'm going to be using the term provider really broadly to mean any professional that a caregiver interacted with in this process. And then, of course, all of the names here are going to be pseudonyms. So the first theme we highlight is that caregivers perceive that bias led professionals to make assumptions about them or their children. Deborah identifies as Black, has a PhD in psychology, and felt like her son did not meet diagnostic criteria because of the assumption that it was, quote, normal for Black children to not meet certain developmental expectations. She shared, expectations for skills were lower, and so he wasn't perceived to have any problems. So let's say that if he was a kid from an environment where they felt like there were more resources available, then there would be a lack of understanding as to why he hadn't met certain benchmarks. But because he was in a Black family, then they were like, he's doing good enough to be in a Black family. Like the expectations for his developmental trajectory was much lower. And since he met those lower expectations, then they were like, he's fine. What's your problem? This quote highlights how some caregivers felt like the bias of providers resulted in their children being held to different developmental standards. And it implies that minoritized children have to show up with more severe symptoms in order to be eligible and meet the criteria for diagnoses or services, just because of the way that they're perceived. Other caregivers worried that provider bias would result in mislabeling of their children. Mary, who identifies as a Black mom, shared, usually caregivers of color, particularly Black caregivers, do not want that designation of having a developmental disability. To have that label, then it means that a student could be possibly written off. That's why a lot of caregivers don't want the special education designation specifically, because historically it meant that most likely you are going to end up in prison. So historically, that designation is not seen as a good thing. It's seen as something to do harm, not help. In addition to bias towards children, caregivers felt like providers made assumptions about them as well. Isabel is a bilingual multiracial mom who self-referred to the regional center after her son's speech stopped at the age of 2. Isabel describes how bias around her language abilities were perceived by her providers. They see you and they think she doesn't speak English. I can fully understand what you're saying, but that was a struggle with the regional center, like pushing for some service that we did not request. And the consequence of this, she perceived, is that it took longer to schedule an appointment because of availability of interpreters. And so now she knows to explicitly say that she does not need an interpreter so as to not delay the process. Angela is a Filipina mom and preschool teacher. She came to the pediatrician for a speech referral when her son's speech stopped. She recalls being told to wait and that this was normal, sharing, and then the pediatrician talked to me using the big words for early childhood education and not even realizing maybe I work with kids too. Maybe I have an understanding. I think there's an assumption like you don't really know, so I'm not going to explain it to you. And this highlights how caregivers feel they're perceived by providers in a way that decreases their credibility when it comes to their child's development. For Angela, this bias explained the dismissal of her concerns. She later reflected, if we were white, we would receive the services. Providers would be willing to listen to us more. They'd be willing to negotiate with us rather than telling us this is what you need to do. And these experiences made it so that families did not want to seek out support from the early intervention process. Mary shared, think about all the caregivers who have come to the doctor suspecting something and were written off. So we don't trust the physicians to actually tell us the correct thing because we're suspecting something and it's being written off. For the second theme, is caregivers were made to feel like a burden on the system, where participants reported being told that they're asking for too much or their motivations behind help seeking were being questioned. Leticia is a single mother who had a hard time scheduling an appointment for her son, and she describes her experiences calling and asking the medical clinic to make the referral. She said, and then every time when you ask for a referral, they don't like it. They keep saying, you're asking for a lot of referrals compared to our other patients. I mean, I'm not asking because I'm playing or because I want to see the doctor and have fun. I'm asking because I'm trying to help my child get treatment. And Deborah shared a similar perception. It felt like I was being accused of doctor shopping to be able to hear what I wanted to hear, as opposed to trying to find a professional who would just listen, period. And Deborah further recalled overhearing regional center staff accusing her of trying to, quote, game the system. She said, and those were the kind of things that I heard, like, oh, she's back again, trying to get a service. It's a Black family. She must be trying to get an extra foster care bump or something. Deborah experienced how other people interpreted her persistence in a racialized manner, or consistent with notions that paint people of color as trying to unfairly take advantage of the system. And now for a third theme. In reflecting on the advocacy process, caregivers revealed an awareness of how they had to adjust their behavior so as to not fulfill racial stereotypes, also known as managing stereotype threat. Sarah, identified as a Black mother of a 4-year-old son, shared, I have a pediatrician who's a person of color, and I think if it had not been for him listening to me and not devaluing my opinions, because as a woman and a woman of color, our opinions are always devalued. And if we kind of push for what we believe in, then we're angry or we're rude or, quote, she's just another angry Black woman. So people don't listen to you. And at first I'll say that it kind of intimidated me because I was afraid to speak up or say what I didn't like because I didn't want to be the angry Black woman. This quote reflects the unique burdens that come with persistence as a minoritized caregiver. There's an extra cognitive load that caregivers have to manage, where they might have to be more selective of how they advocate for themselves. And the question this begs is, are there outcomes that caregivers might have pushed for but didn't because of not wanting to fulfill the stereotype threat? So for the implications, so we talked about how current literature really focuses on differences between health seeking in terms of white groups versus minoritized groups, and how this is leading to disparate outcomes in terms of who gets services. And critical race theory invites us to think about how the process itself racializes caregivers. So our results offer a more complex picture of how families are interacting with the system and how they're experiencing racialization within it. We talked about dismissal from providers, instances of bias, stereotype threat, and being made to feel like a burden. So in terms of future research, it needs to look beyond group-based behaviors and more on mechanisms of racialization, especially aspects of structural racism, which wasn't covered as part of this project. And then also focus more specifically on anti-Black racism, as this project covered racism more generally. In terms of clinical care, we as medical providers and trainees need to not only be aware of our biases, but also question the structures that these biases are created in and are perpetuated in. And so this means that any anti-bias training really must be couched within a larger anti-racism training. And this will allow us to make sure that we're actually taking minoritized caregivers' concerns seriously and strive to understand how that caregiver relates to a developmental diagnosis given the intersectionality of racism and ableism. And with that, I have so many people to thank for this work. I'm going to start with my amazing research mentor, Dr. Suzanne Martin-Hers. She was with me from the very beginning, helping me understand what IRB is and what a literature review is. So thank you, Dr. Hers. The co-mentors, Dr. Jen James and Dr. Jyoti Marvin, thank you so much for your unyielding support throughout this process. My community advisor, Kenya Martinez, who's watching right now, and my research colleagues, Adriana Guzman and Javier Aguayo. And then, of course, my deepest gratitude towards all of the caregivers who so graciously shared their stories with me as part of this process. And of course, to the JMP faculty and executive team, thank you so much for your support in the last 2.5 years. It's meant so much. To my incredible classmates who I've learned so much from, and I'm sad to be leaving the next year. To 1912 housemates, my volleyball team, and of course to Tommaso and my parents for their unyielding support as well. Thank you.
I'm curious how much you saw in the extension of racialization to the types of disabilities that were being evaluated for, and if parents, caregivers had an experience of like what they saw as the probable disability being kind of changed by evaluations and biases by providers, or if they had that experience at all.
Yeah, I'm going to try to repeat the question. Whether the racialization and experiences of racialization kind of change depending on the disability category. That was the best summary of that. But I think what comes to mind is I think that I was like talking to, I think I gave the example of Mary, how she had this worry that this developmental diagnosis would result in a later labeling in the education system of emotional disturbance, which we actually know that children of color and Black children particularly are more likely to be labeled in the education system, and more generally labeled in subjective diagnoses that are more likely to put them in exclusionary special education classrooms. And so I think that that's the kind of like labeling that stands out when we think about her example. And I'm not sure if it really made sense towards the end, but that's what I was trying to say around like why it's so important for us to really understand how a parent or caregiver relates to developmental diagnosis, because there's so many structural reasons as to why they might see a diagnosis a certain way, and especially in terms of how it impacts educational opportunities disparately. And so I think, whatever we can do as as providers to be able to understand what that diagnosis means to them is particularly important. But thank you for that question. Oh, lots of questions here. I'm doing that.
Yeah, so I'm curious if caretakers describe having children that have multiple chronic health conditions in these interviews, and how they compared with each other when they describe their experiences of interacting with providers.
So the questions, if there are caregivers who had children with multiple chronic conditions and how that changed their experiences as they were interacting with providers. Unfortunately, I don't think there were any other conditions that were captured. A lot of this was really focused on developmental diagnoses, and I think maybe there were some comorbidities in terms of like an ADHD with an ASD diagnosis, but I didn't really encounter additional chronic illnesses as part of this project. But I think that's a really good question, important to think about how that would impact.
One last one.
Okay, one last.
Yeah, I just have a quick question regarding, because you mentioned all the three different stakeholders, like educational services and as well as the healthcare providers.
Yeah.
Were you aware of any kind of like advocacy happening from like the healthcare providers in terms of educational related mental services, or even other external organizations being that kind of advocate for these families?
Yeah.
Educational services?
Yeah. The question is, like, what role does healthcare or other organizations play in advocating kind of within the school system, it sounds like. And I'm going to speak from experience and not from this project. I have seen how pediatricians can show up in the or individualized education plan IEP process, where they're able to advocate for what they're seeing medically or clinically and make sure that that child has the right supports inside of the classroom. So that is possible, and that's like such a beautiful role that a pediatrician can play. And I hope that like that becomes that integration between kind of the health system and the education system can continue, because I think that's a really amazing opportunity for us as clinicians.
Thank you.
All right. It is an absolute honor to introduce my classmate and dear friend, Ryan Lofty. Ryan comes to us a native of Georgia. He attended UC Berkeley for undergrad, studying chemical biology with a minor in public health policy in Southwest Asia and North Africa, SWANA. Before coming to the JMP, he served as an animator for the Junior Youth Spiritual Empowerment Program and a tutor for the Ruki Institute in Metro Atlanta. He also spent time traveling around SWANA countries, connecting with friends and family from across the region. These experiences shaped his interest in developing a medical curriculum for how to best care for SWANA communities. What I admire most about Ryan is his unyielding commitment to his communities. He's a fierce advocate wherever he goes, whether in PDL, clinical encounters, or on social media. Ryan lights up any space he walks into with his authenticity and ability to instantly make people laugh. On a more personal note, Ryan has taught me what it means to show up for your friends. I think we've all benefited from a handmade budding June on our worst days. So without further ado, please help me in welcoming Ryan.
Yeah, he said just make sure the connections were.
Which one is this?
Yeah, and maybe that.
It's okay, but I don't see it
You know,
showing that.
while they're getting that set up, there's a couple of things I want to ask of you all that I would really appreciate. So set your expectations super high, so if I disappoint you, you give great questions. The other one is please take pictures, because I want to send them to my mom. And then I just really want to say that designing a medical curriculum is like really hard. Also, a really good time. And I just want to give props to everybody in medical education and also the faculty and staff at the JMP, because like some of us give like critiques sometimes, and then we don't realize how much work it goes into it. So like, thank you so much for all of you. My co-curriculum developer is here. Say hi on the side. Thank you so much. Okay, so the title of my curriculum specifically is Caring for Communities from the SWANA to Metro Atlanta, a medical curriculum for SWANA patients and other transnational diaspora communities. So I want to start by defining what is SWANA. So SWANA stands for Southwest Asia and North Africa, and it's a term to specifically replace colonial terms like Middle East, Near East, Arab world, or Islamic world. And I want to introduce you to the curriculum design team. So myself, thank you. And then I also want to share a little bit about curriculum inspiration. So for this project myself, I want to just like mention, we talked a little bit on palliative care and hospice care. And so like, I'm feeling a little bit anxious and a little bit like, I will say upset, especially because the motivation for this curriculum is specifically the passing of my uncle, my dad June, this past August. He was diagnosed with lymphoma in March. And that's been something that's been sitting with me. I think there's been a lot of like traumatic experiences that both I'm sitting with, families been sitting with, and then the treatment that we received from medical staff, whether the best of intentions, was extremely harmful and extremely racist. So I want to name that. And then I also want to share a prayer that my mom recited, his sister, with you all, if you will play. Can I get some help playing it, please?
I need to take the arrow to the other screen and click on the, yeah, there you go. And
Oh,
click on the,
incredible.
yeah.
And one of the reasons why this prayer means a lot to me too is because it's both pronunciation of this prayer that comes from Farsi, but it's written in Arabic from the Baha'i faith. Okay, fine. And if not, I can also say it too. Or actually, better yet, we're going to go ahead and pause the clock. I know we're kind of feeling a little bit away about time, but we're going to go ahead and click pause the clock because this is important, and we're going to go ahead. Okay, let's try that one more time. And if not, I got it on my phone, so let's do it on my phone. Yeah, I got it.
اما جعلته لك المؤمن كيف تحصل منه وجعلته نورا لك ضياء كيف تحتجب عنه.
Great, thanks for bearing with me on that. So I want to share a little bit about the values and motivations for this curriculum. So before we even went into design the modules or any of the work that would go into it, we centered anti-racism, decolonization, disaggregation, and healthcare as a right as the 4 values going into development in general. And this takes us to the curriculum design. So we use the 6-step approach for curriculum design, medical education, which both involve a general needs assessment, a targeted needs assessment of who the learners we're trying to reach, establishing goals and objectives, and then thinking about educational strategies we want to employ. The implementation evaluation stage is the next step of this curriculum and the hopes for the future. So it's a little bit of table of contents, and we'll go into the needs assessment. So for our needs assessment, we broke it up into 2 categories, a review of the literature and then a qualitative interviewing process. So for a review of literature, this comprised a series of articles. There you go. A series of articles that we would look at in PubMed, as well as thinking about what comes up on social media. I know some of my classmates don't think that social media would be the best form, Shali. But I really believe that TikTok, Instagram, these forms of social media have like a very powerful avenue of experiencing people's experiences. In addition, we use Meta Portal that has a lot of existing medical curriculums, as well as Luma, which is a Arabic-specific database that has a lot of resources there. And then also think about YouTube that has a lot of people's experiences that are listed there, as well as news resources. And this is a list of some of the search terms that we did use. This is not a comprehensive list, but it's just a little bit of taste for you all to kind of dabble in. And then from that, article after article, specifically we kind of wanted to start off thinking about racism as our root cause approach. At the very beginning when we developed this curriculum, then we thought about South and Southwest Asian experiences, specifically with diagnoses. That took us to thinking about how ancestral trauma also shaped people's experiences and their healthcare experiences, and what are their health realities now. How can decolonization be an approach that we think about when we want to think about patient health and how we can care for the person as a whole, especially thinking about intergenerational trauma from that. How disaggregation is a barrier towards providing adequate care for people who are lumped into specific racialized groups. Thinking about how Islamophobia is not just impacting Muslim patients, but our racialization is not just our skin pigmentation, but it's our outward presentation, and how that's very central in terms of patient care and people's well-being and health. And thinking about complementary alternative medicine, or how I like to prefer ancestral medicine, the moniker that I would like to use, ancestral medicine, both the herbal practice of it as well as the spiritual and the religious practice of it in patient care. And then finally, thinking about how structural forces need to be addressed specifically by having toolkits and frameworks in place, specifically as caretakers or as providers when we think about caring for the whole person, as well as ourselves too as racialized people. Now this takes us into qualitative interviewing. So part of the reason for wanting to kind of pair qualitative interviewing with our literature review was thinking about how can we raise the experiences of people who are doing this work right now and working with non-citizen patients as well as specifically SWANA patients, expanding the scope of the topics that we probably didn't talk about in our initial review for the literature review, and then thinking about how can we connect and reconnect with friends, family, and community members back in my home state of Georgia. So this takes us to Metro Atlanta, and I want to introduce you to kind of like a rough layout of the land. So there's the inside the perimeter of the ITP, and then outside the perimeter of the OTP. And we're going to be looking at a specific community called Clarkston, Georgia, just outside of the perimeter. So this is Clarkston. It is one of the largest refugee resettlement communities in the country. It houses one of the largest communities of non-citizen people in the state. And I want to give like a little bit of an introduction to kind of what the healthcare landscape there looks like.
So I would describe this in this general area. We see this one little descriptor of Emory University Hospital that sits relatively close by Clarkson, about 10 minutes drive away. However, there's a difficulty accessing care there specifically because care can be more difficult for patients who don't have health care or insurance coverage that will take them there. In addition, the county hospital, the nearest one, is Grady Memorial Hospital in downtown Atlanta, which is between a 30 to an hour drive away from Clarkson. In addition, Grady's coverage does not kind of go into the county that Clarkson sits in. So what we're left with is the Clarkson community. Ooh, let's go back. What we're left with is the Clarkson community being cared for by primarily volunteer organizations, local health providers, and people who are doing more health professionals who make their time available, whether it be through religious organizations or nonprofits. And just as like a quick summary of what the community looks like, over half the population in Clarkson are foreign born. Over 60,000 are refugees, and we don't have a number for the number of SWANA people that are in Clarkson because we don't disaggregate SWANA from the term white. So instead, we can give some estimates. So we have an estimate of 3.7 million people of Arab ancestry in the United States, and between 500,000 and 1 million people of Iranian ancestry and origin. So in terms of our interview methodology that we use, we had 10 semi-structured interviews with health professionals in the Clarkson community. We use virtual Zoom interviewing, and we transcribe these and just follow through the line-by-line coding into the phenomenology, or use of phenomenology. And I listed out just kind of like what our timeline looked like, but that's not important for you all. But it's just up there in case you all want it. Now, in terms of our coding analysis, we had a general of 8 themes that kind of emerged from this interviewing, but I want to bring our attention to these 5 themes over here: Clarkson health professional experiences, outlook on CAMS, barriers to care, healthcare professional patient communication, and then provider-reported patient experiences. And so these 5 themes end up kind of, we flesh these out a bit more, the team of undergraduates and I, to figure out like what were the sub-themes from them that are the most pertinent, that we also felt like overlap specifically for in being implemented in a medical curriculum. And just to maybe give a descriptor of some of the things that kind of came up in our medical curriculum, one of them is addressing communication styles between provider and patient. Another one is thinking about structural factors of service that serve as barriers to care, like accessing basic needs or community segregation. And another one, for example, is thinking about faith and religion in terms of culture and coordinate care. So then regrouping and sharing. So it's great to be doing all this interviewing, but then if we paint a picture that's not accurate to these people, to people who are doing this kind of work experiences, then it kind of falls apart. So for us, it was important to regroup with administration at Clarkson Community Health Center, who we partnered with, to be able to share what were the findings, collaborate on addressing any of the challenges that emerged in the curriculum, modifying the course structure, and then also establishing a shared vision going forward for what the medical curriculum could be addressing. So we established our learners from this. We interviewed nurses, we interviewed physicians, physicians associates, and pharmacists. And we also kept in mind that there's more people that are in health professional programs and practice that aren't just these 4 groups. So there's just some listed over here, and you can appreciate the osmosis graphics that were kind of going on there. And want to say that this medical curriculum is created with the vision of being applicable to all of our health professional learners who want to serve in a volunteer medicine based practice. Now, in terms of our goals and objectives, so we identified 3 main goals and objectives to describe the impacts of structural forces of violence on SWANA patients, to apply frameworks and toolkits to support learners in developing best practices in the care of SWANA patients, and then thinking about how can we develop a community intervention from this. There's now an actual, tangible, actionable thing to come out of the learnings that are had by the learners in the curriculum. And then we took those 3 goals, and we put them into learning objectives that are modeled after Bloom's taxonomy. So the text is a little bit small here, so I'm going to turn my head a little bit to just describe some of them. So identifying colonialism and racism in SWANA communities, recognizing how communication and beliefs and biases are important in patient care, giving both feedback interprofessionally between colleagues, as well as trauma-informed approaches to with patient care, and then also developing and describing how interviewing for complementary alternative medicines, aka ancestral medicines, and needs for non-citizen patients can be brought up, as well as identifying organizations in Metro Atlanta that are serving and doing this work, and then also pairing it with a potential structural intervention project for learners to engage with. So in terms of educational strategies, we employed 4 different educational strategies, one of them being asynchronous module-based learning, synchronous sessions, clinic encounters, and then community intervention projects. So what does this look like? So for the asynchronous module-based learning, we start off with a series of pre-work. So before any of the actual module content, this looks like reflection questions. Learning objectives will be identified, making an acknowledgement of the content that's going to be within the curriculum, and then what the work that needs to be done, as well as pre-module surveys. That takes us to the module portion of the curriculum, which is both required material, including social media, Shelley, and and additional literature, as well as optional literature that can, like, learners who are interested in those topics and explore more. And then finally, post-work, so group discussions / individual reflection questions, and post-module surveys to gauge what students end up taking from the curriculum. For our synchronous sessions, this looks like curriculum co-creation. So this looks like having a student lead for that week who will summarize the material and who will establish discussion questions, as well as try to find a way to incorporate optional material. And then from that, be able to have a student scribe for that week to also kind of take notes of what emerges from the discussions. And then second, we have role-play and case-based scenarios. So role-play scenarios specifically for people who want to interact, giving feedback to their interprofessional peers. On case-based scenarios, we're talking more specifically about traumatic, very difficult topics, specifically about the care of people who may have gone through torture, or people who have gone through non-citizen experiences that are very difficult. And this is to name the harm and the social forces that are at work in these interactions. And so we have a modified course structure too, as you can imagine, within volunteer health clinics, you don't have a cohort of learners. So it's important to be able to adapt this curriculum to a smaller set of learners maybe at these clinics. And then also for medical institutions who are maybe interested in adopting this curriculum, having the student leads present, the scribe present for those that have a cohort of learners that are more than 14. So for our encounters, we have a requirement that there be 3 encounters, and the follow-up that we have 2 notes that be kind of summarized by or made by the learners, within ISBAR being one of them that is kind of more open to interprofessional learners. That may not necessarily be physicians, physician associates, or nurses. And then thinking about how they can go back to previous work that they've done for their existing coursework and modify that to match the goals and the learnings from this curriculum. And I'm zooming through here, and I'm going to slow down in a second, so forgive me if I go over a little bit of stuff. But for our structural intervention project, this specifically is looking like partnering students or partnering learners with a community organization that they select for, they choose through some kind of available form in the very beginning of the course. They get paired with a group that may be interested, they have compatibility with, and then hopefully we're applying for funding right now to make it possible to have like enough money to actually have some kind of like substance in the interaction with the community organization. And should learners be limited on time or not be able to interact with this, have the option to either do a policy memo or do a op-ed on the topic that they're interested about and actually submit that for publication, have maybe some kind of community impact from that. Now, in terms of the course content, we're going to go into that, I know, but it's okay. We're all good. So in terms of the course content, for this introduction to the course specifically for value setting and goal setting for the beginning of the course, I have a module on racism in medicine and practicing anti-racism. So it begins with an introduction to anti-Black racism, and then it also draws on a lot of the readings that we've already kind of been exposed to through a lot of programs, and takes it one step further, looking at non-citizen patients' racialization as well, specifically think about the Swana region. In addition, thinking about colonialism in medicine and how decolonizing medicine really does impact patient care, and how it continues to exist today, whether it be with the occupation of Palestine, whether it be today with the situation in Iran as well. And when we think about race and ethnicity and disaggregation of Swana, this is kind of in a continuation of this conversation about lumping groups into the term white or lumping groups into the term Asian, and not actually giving a conversation about like how this more structural forces will work. In addition, we have a module on Islamophobia and impacts on health. So we may think Islamophobia only impacts Muslim patients, but it also impacts anybody from a region that's been racialized to be Muslim. And this kind of builds on the need to having more specific care that considers this aggregation, as well as thinking about complementary alternative medicine, which again, ancestral medicine, and both having herbal medicine practices, as well as the spiritual Buddhist implications for patient care as well. We also have a module on racial trauma and healing, so it doesn't do anything for us just to know about all the statistics about like healthcare disparities when it comes to race and not give anybody the tools to actually address them. So having a module on that as well. I know we're going over, but it's okay still. So finally, the next set of 4 that we have is specifically on mental health as a hidden disability, which takes us into care and support of non-citizen patients. And so thinking about how there's a lot of traumatic experience, whether it be experiences with torture, experiences with loved ones who've experienced some kind of traumatic event back in their home countries before coming. So these are put subsequent to each other intentionally. The next 2 are specifically on provider-patient communication, whether it be through telemedicine or through interpretation services. And then having a module specifically added towards the end on addressing carceral medicine. And I think this is really inspired by one of my classmates' work who's going to be speaking soon, Ria. And I think it was really important to consider this, especially in how this impacts, comes up in healthcare specifically. And finally, we have 2 modules specifically on training resources to support patients in Metro Atlanta. And then how do we translate those training resources towards like, what do we do with it? So we're going to have advocacy training as well for the final module. Okay, so in terms of implementation evaluation, we currently are working with volunteer organizations in Georgia, so we're planning on securing funding to be able to implement the last 2 modules in this curriculum. In addition, we have access to UC Berkeley external Canvas page that we're planning on delivering the curriculum to make accessible to anybody who like access to this curriculum, whether you're an institution or an individual. With having a requirement that institutions who adopt this curriculum also make a monetary investment to the curriculum, whether it be through the intervention project or something else. We're thinking about submitting to Meta Portal, as well as a follow-up conversation with medical schools that medical schools and nursing schools that we've talked to in Georgia as well as in California. And then something we haven't tried yet, but we're curious about trying is outreach to interprofessional programs and healthcare professional programs in Georgia to get students overall interest in the curriculum, and then also just taking that back and presenting it to the heads of these organizations and institutions and say, okay, we have these people who are interested, are you interested as well? And then also now we've got to assess the impact of this curriculum, so maybe doing patient satisfaction surveys as well as the conditions of providers surveys as well. And the last thing I want to just mention is also just like reviewing the module surveys that we're going to be conducting as well. I want to go ahead and just like say I'm super grateful for the funding that we received for this. So the Center for Race and Gender provided funding for this. The Foreign Language and Area Studies Fellowship provided funding for this, even though I didn't read that quote in Arabic in the very beginning. And then the Joint Medical Program supported it as well. And I want to give a big thank you to both Ami and Susan. Ami like guided me through this project from the very, very beginning, and very deeply appreciative of that. So big round of applause for you. Susan literally made everything happen when it comes to like editing and paperwork and this thing, and it's literally incredible how you really I also want to thank Dr. Gulshan Harji and Dr. Gina Papa at Clarkson Community Health Center, the recruitment for this project, as well as the motivation to keep going and the scoping for the curriculum would not have been able to be possible without them. So I want to give a big thank you to them as well. And then I want to thank Jose Collado, who couldn't be here because he's sick today, but he's watching. And I want to say a big thank you to Jose. Big thank you to Sihan. Go ahead and stand right now. Okay. And then Sam Samani as well. And then the last thank you I want to give to both my parents. We've had a very, very difficult year, and I think support through life and everything is like an understatement. Like I could go on and on about it, but I just want to say there's like a level of deep appreciation both that I feel, and I know that like, all of you have come to know me. If you even like me at all, like it's because of that. And then I want to leave you all with a quotation: "1,000 upon 1,000 of what thou hast asked for thy parents shall be thy recompense." And so I want to leave you with a quotation. I know we don't have time for questions necessarily, but I want to say thank you so much, and yeah,
All right, I think let's break until 2:45. Okay.
Okay. So hi everyone, I'm Ryan again. I have the honor of presenting Ria Desai, one of my very, very good friends. Ria comes to us from Ventura, California, which I don't know what it is, but California. They previously studied at UC Berkeley from their undergrad, and they worked in the UCSF Department of Epidemiology and Biostatistics. And they came into this project connected to this work with organizing and policy work. I want to share really briefly that Ria also went on to pursue a fellowship at the Human Rights Center on the causes that are important to her. And then I want also to share too that in terms of PBL and our coursework that we've had at the Joint Medical Program, Ria has been a constantly centering force and has been someone who's advocated for communities that she cares about and she believes that should be represented within our learning spaces, and I really appreciate how she's shown up for all of us and for people who are not in the room too.
Thank you so much for that generous introduction. So first of all, to understand the grave importance of compassionate release, I want to start with a video of Ms. Rhonda Felix sharing her experience.
I'm the principal of 6.5 years in
Ms. Rhonda Felix and her family immediately applied for Damari's compassionate release, but months later he passed away in prison, still waiting for his application to be processed. Compassionate release failed their family, and today I hope to share some of the things we've learned about barriers to compassionate release. Compassionate release is an umbrella term for programs that provide early release for terminally ill, very sick, and incapacitated people. A policy like compassionate release has become necessary in the context of mass incarceration. Starting in the 1970s, incarceration, an inherently racist structure, exponentially increased with the implementation of racist sentencing policies that were designed to increase admissions to prison and to lengthen the amount of time served on a felony sentence. As a result of mass incarceration, the number of people aging in carceral settings increased 280% in the United States between 1999 and 2016. Mass incarceration has created the structural conditions for people to age and die in prisons, causing the need for policies like compassionate release. In California, there are two mechanisms for early medical release called compassionate release and medical parole. The policy called compassionate release was first utilized in the 1990s in a period of growing mass incarceration, widespread illness and death during the HIV/AIDS epidemic. Incarcerated women in California and their advocates led a near impossible fight for decarceration. In 1997, compassionate release was codified into California law. But data on compassionate release between January 2015 and April 2021 showed that only 329 applications were started for 304 applicants, and only 53 people were released in time to pass away with loved ones on the outside. An outcome that was 2 times more likely than release was death. 91 people passed away before the process was completed. And the second compassionate release policy in California is called medical parole, and this was passed into law in 2010 and expanded in 2014 through a court order as part of an effort to reduce prison overcrowding. Between January 2016 and May 2021, 295 people applied for medical parole, and 108 people, about 40%, had been placed on medical parole. However, in late 2021, medical parole in California was shut down. An audit by Centers for Medicare and Medicaid found that patient rights of medical parolees at skilled nursing facilities were being violated. At skilled nursing facilities, some patients on medical parole were denied the right to cell phones, were shackled to the bed, not allowed visitors, and unable to leave the skilled nursing facility. The program is now closed to all except those on ventilators, and the remaining people on medical parole, about 76 patients, have been transferred to a decertified skilled nursing facility. Throughout the pandemic, compassionate release has continued to be underutilized. Even though data from the federal receiver showed that 17,000 people were medically high risk for death and disability due to COVID-19. And through the study, we try to understand the barriers to compassionate release to help shape effective policies within this complex medical legal system. We conducted a descriptive analysis of compassionate release data from CDCR obtained through a Public Records Act request. Those were the findings that I discussed earlier. And we also spoke with 18 people who provided medical care, support with compassionate release applications, and advocacy for terminally ill and disabled people in California prisons. We began with the open coding framework and developed a code book that we used to code transcript using Atlas TX software. Our findings will discuss the three main components of release: medical eligibility, a post-release plan, which can include where a person would be housed and how they'd receive medical and nursing care after release. And the third component, determination of threat to public safety as written and defined in the policy. The process for compassionate release is long and has many steps. For both processes, medical eligibility is determined in a similar way. The application is started by the person's primary care provider. You see that in yellow. And then the application moves to public safety determination in orange, red. For compassionate release, the public safety is ultimately determined by the sentencing court, and for medical parole by the Board of Parole. A post-release plan is needed to start compassionate release, but for medical parole, a placement at a skilled nursing facility is identified after the medical parole is granted. And while the details of each of the steps are difficult to understand in the time that we have, what's clear is that compassionate release is an incredibly complicated process for anyone, and especially for people at the end of their life. Getting past each step requires an extraordinary amount of advocacy, which means that release is the exception and not the rule. First, medical eligibility for both programs includes support with activities of daily living, and for compassionate release, medical eligibility also includes a terminal prognosis. And while there is an eligibility criteria, there's no standardized process for identifying people who are eligible. In the absence of a standardized process, providers have the discretion of submitting applications. And while we learned many cases of exceptional doctors who put in the extra effort to advocate for their patients' compassionate release, one provider shared, "The provider in some ways is the gatekeeper because they initiate the process. I have a very compassionate group of providers that I work with, but I can tell you it's not necessarily the same at all prisons. It does require a degree of buy-in from the provider. I mean, it's compassionate release, so that is the starting point, is a degree of compassion." Some institutions had systematic processes for identifying eligible patients and initiating applications, and the impact of institutional support is visible in this quote from a loved one. "We didn't get any support from Prison 1, which is the prison he was originally in, and so when he was transferred from Prison 1 because they couldn't keep him there, they transferred him to Prison 2. He was only in Prison 2 for about 3 weeks, and then they transferred him to Vacaville. Vacaville is, I want to say, honestly, that was the one place that actually tried to do the paperwork and push for the compassionate release. The social worker and the doctors in Vacaville CMF actually pushed." After medical parole has been granted, placement for medical parole is centrally identified. However, for a compassionate release, a post-release plan has to be documented before our application can even be started. So the onus is on patients who are disabled and dying to identify where they might go after release. Sometimes this looks like family members or loved ones being willing and able to provide housing and care to people after release. And without family support, people need the support of a doctor or access to social work to be able to find a housing placement after release. However, institutional support for post-release planning greatly varied across institutions. A social worker shared that CHCF and CMF are the only two that have medical social work. From what I understand, there's none at the women's facilities and none at the men's facilities. There are social workers, mental health social workers, but there are no other medical social workers. And at the institutions where there aren't medical social workers, my understanding is unless there's family or friends, there's no way they will apply. And even with institutional support, finding a placement for long-term care can be very difficult. A doctor shared, there's no place in society that cares for people like that. Just like the mentally ill man under the bridge in downtown Berkeley, if he becomes ill, we don't have anywhere to put him either. We have a constitutional requirement to provide health care to people who are incarcerated. We don't have that requirement for people in the community. And once this incarcerated man is out the door, we may not be able to care for him. And that's a societal problem that's way bigger than prison. Accessing long-term care is not a protected right, and skilled nursing facilities reproduce bias against people with histories of incarceration and exert detrimental power over people being accepted and admitted for care. The final criteria for release is public safety determination. An attorney shared that there's no real standard of proof that the court must find beyond a reasonable doubt that the person is a public safety risk. It's so broad that they can rely on anything they want. The lack of a standard of proof allows for major discretion in how threat to public safety is interpreted. While medical eligibility and public safety are supposed to be separate criteria, medical conditions can be used as a proxy for public safety risk, where ability, mobility, and capacity are considered risks to public safety. An attorney shared that the level of their incapacitation helped people get released. Guys who are in wheelchairs, guys who are bedbound, it's pretty obvious they're not doing well. They're not at risk to reoffend, so what really helped too is when the medical professionals would be able to say, look, this really is something where they have like 2 or 3 months left. That helped. Public safety decision-making can rely on people's medical conditions as an alternate means of carceral restriction, a much more narrow implementation of medical eligibility compared to what's written in the policy. As we overwhelmingly learned about barriers, we also heard of a few positive outcomes. A social worker shared that there was someone who had been incarcerated for a long time, and he got approved on compassionate release and he went to a skilled nursing facility. We'd found a place for him to go to, and he had 10 days before he died. But during those 10 days, family and friends were able to visit him every day because we found a place that was near part of his community. And they sent us a couple pictures, and they actually let us know when he died. It was great to know that, as brief as it was, he got his Carl's Jr., he got his, I think Cinnabon was one of his things. He got so many things and had so many people who were there to be able to come and visit him and just be present. So that was a wonderful outcome, hands down, for him. The fact that 10 days of time in freedom was a wonderful outcome tells us a lot about how much more needs to be done. While some are released through the work of exceptional advocacy, compassionate release is a structurally impossible pathway to freedom for many disabled and terminally ill people facing incarceration. A coalition that I was a part of, initiated and led by women impacted by the criminal legal system, worked to change that with Assembly Bill 960. In October 2020, the governor signed AB 960, which expands eligibility to people with serious and advanced illness with an end-of-life trajectory and removes the criteria that people require 24-hour care. The secretary was also removed from the process so that after medical eligibility is determined, people's applications will go straight to the sentencing court. This is an important step forward, and still many barriers remain. The solutions for compassionate release are not simple, and we need to address structural racism in order to have meaningful change. This video by Forwardless Production tells the story of someone currently caught up in the barriers to release.
Mr. Gary Cooper did not meet the medical eligibility for compassionate release and remains incarcerated. And while we hope that the changes made through AB 960 allow more people like Mr. Cooper to have a chance at release, ultimately, compassionate release is a political decision, and public support for releasing incarcerated elders is critical. Compassionate release raises new questions about the moral implications of sentencing people to die in prisons and forces us to confront how the reality of incarceration is itself deadly. We need transformative change to make death in prisons unimaginable so that we can work towards making life in prison unimaginable. And with that, I'd like to thank Professor Jennifer James for being an incredible mentor and collaborator. And this work wouldn't be possible without her. To the AB 960 Coalition for being leaders and an inspiration for this work. To Professor Obusogi, my co-mentor, for providing a theoretical foundation at the JMP. To the JMP community, all faculty, staff, and peers, and my friends. And a special thank you to my parents who are watching on Zoom. I love you, Mom and Dad. And to my partner, Marco. And I'd like to end by standing in solidarity with my union, UAW, with workers on strike right now, and I'll leave this up as some of my other classmates have done as well.
Are there any other proposals or bills, proposals or bills that are like on the docket that are going to be reviewed by the state legislature?
The legislative cycle just ended for this past year, so I'm sure there's like a lot of momentum and work happening. I know that the Racial Justice Act passed in the past legislative cycle, and that was implemented retroactively for some changes that happened around resentencing. And there's a lot of movements and efforts around retroactively changing sentencing policies like mandatory minimums and the 3 strikes law. I can't tell you any specifics, but yeah, those are. I would just say for all of us to follow the leadership of Black abolitionist organizers in this work and follow and support in what's being led in California and in the U.S.
Really great career. I learned a lot, which is hopeful and sad that it took this for me to learn some of it. Is there a connection between what crimes people are alleged and convicted of and like how they're released? Like, is that at play at all, or the amount of their sentence, or is it? I guess it wasn't clear to me if that was part of what whoever's making these decisions are considering.
Yeah. So the question was broadly, what is being considered in like public safety determination if the crime of conviction is a part of that. And it can be, and I think there's arguments about whether or not that makes sense when circumstances might have changed a lot from what initially happened. But one of the barriers for public safety determination is sometimes just the reason for incarceration. And people and judges will not consider something that to them on paper seems like too violent, without really considering the context or like who the person may be now and what their situation is now.
Thank you very much.
Before I go, I'd love to introduce our next speaker. Kate Radcliffe is from San Diego, and she has an undergraduate degree from UC Berkeley. Before starting medical school, Kate was at UCSF and NYU working on research with geriatrics and vulnerable populations. She chose her project driven by her interest in caregiving and dementia, and as long as I've known Kate, she has been committed to the care of older adults, and her work today shows that. Welcome, Kate.
Hi, everyone. I'm Kate Radcliffe, and I'm going to be presenting my work entitled Care Setting Transitions for People with Dementia, Qualitative Perspectives of Current and Former Care Partners. So to take you through the agenda today, not very different from my colleagues, I'll start with background, problem statement, methods, results, and finish up with some implications. So I'd like to start with some background about care settings and people with dementia. So dementia affects 11% of people age 65 and older, and that number only grows as people grow older. And 11 million people act as unpaid care partners for those folks with dementia. So here, when you hear the term care partner, this is a term that's becoming more popular to replace the term caregiver. And care partner really is meant to emphasize the partnership between the older adult with dementia or any chronic condition and the person providing care. So just think caregiver when you hear care partner if it feels confusing. And older adults prefer to receive care at home, but institutionalization becomes very common as dementia-related care needs escalate. We know that factors that contribute to institutionalization include higher caregiver burden, worse functional impairment, worse cognitive impairment, and worse behavioral symptoms of dementia. We also know that the decision to institutionalize a person with dementia is very challenging for those care partners. And in this context, care partners really is referring to close family or friends rather than a professional paid caregiver. So generally someone with a close relationship to the person with dementia. We know that feelings of guilt, doubt, and decreased self-efficacy are very common for care partners before, during, and after a transition out of the home. And care partners of people with dementia want more anticipatory guidance from clinicians related to these decisions. Healthcare providers, even those with a lot of expertise in dementia, are generally very underprepared for these conversations. So the aim of this work is to identify what specific guidance from healthcare providers will assist care partners to navigate care setting decisions, and to compare the perspectives of care partners who are actively caring for people with dementia to those of former care partners of recently deceased patients. For this presentation, I'm talking about two types of care partners. The first is those current care partners who are actively providing care at the time of the interview, and the second are former care partners of recently deceased patients. So they're able to give a retrospective view of the caregiving experience from diagnosis until death. For this work, I relied on semi-structured interviews that were conducted from November of 2018 to September of 2019, and they were with those two types of care partners, current care partners of people with mild to moderate dementia, as well as former care partners of decedents. They were all recruited from a tertiary memory clinic in an urban center where they had at least one visit. And for the folks with dementia, they could have any type of dementia syndrome, including Alzheimer's disease, Lewy body, or a less common variant. So this study is a secondary analysis that focused on a concept that was present but not specifically addressed in the primary analysis. The primary analysis for this study relied on topics related to caregiving more broadly, as well as some discussion of palliative care for dementia. However, the interviews were so rich and full of so much discussion of the caregiving journey, including care setting discussions, that we went into to conduct this secondary analysis. I utilized the constant comparative method, which is a method that falls under the umbrella of grounded theory, where themes emerge from the data. And the goal of constant comparison is to uncover similarities and differences, refine categories, and describe patterns. So I used care partner type as the unit of comparison to highlight differences faced by current care partners and former care partners. So the analytic steps that I undertook included data immersion, code development, and generation of memos, diagrams, and data matrices to compare between and across data. This is a lot of fancy words to just describe a set of techniques that aids in uncovering codes from different perspectives to refine the codebook and to describe findings. The codes were developed based on participant type, either current or former, and the study team met regularly to ensure accuracy and fidelity to the codebook. So for my results for the participants, we had 31 care partners, including 16 current and 15 former. They were primarily females, spouses of the person with dementia, and well-resourced. Worth noting, I think, is that 5 of the care partners were LGBT spouses or domestic partners, so there's some diversity in terms of that spousal relationship. Continuing with the results for care setting, all of the current care partners were caring for the person with dementia at home, and they're relatively early on in the dementia journey. We quantified this using the MMSE, which is a tool used to assess for cognitive impairment, and on average, the people with dementia being cared for by current care partners scored moderate, so they're still relatively early on. On the other hand, the former care partners were looking back at the entire dementia journey from diagnosis until death, and they described 3 different care setting arcs. So the first was home care, where they were at home until death, and that was the case for 6 out of the 15. The second was short-term institutionalization, where they were cared for at home mostly, but some periods in non-home settings. And for example, there was one care partner who described admitting the person with dementia to a nursing home for a year or 2, and then when circumstances changed, they actually came back home. So that was the case for 3 out of 15. And then institutionalization was the last group, where the person with dementia moved to a long-term care facility without the intention of returning home. And I'm being a little bit intentionally vague here about the use of long-term care facility, institution, and that's just because there was so much diversity in terms of whether people were in nursing homes, residential facilities, group homes. So I really want to keep things a little bit more broad, but there was a lot of difference in terms of those actual journeys and the types of institutions where people ended up. So this figure represents a bit of a spoiler, but really just a primer for what we're going to be talking about for my thematic results. This is a figure that summarizes the key findings from the entire study. So at the top, you'll see there is an arrow marking diagnosis, and then as it progresses, as the person gets closer to end of life and eventually death. And under the dementia diagnosis area, early on in the diagnosis, there's a lot of uncertainty about prognosis, which influences the care setting decision. And as time goes on and the person with dementia gets closer to death, care partners really want actionable recommendations from providers. So you can see everyone started off at home, as I described for those current care partners, and then over time, they will stay home and have increased health, or go to an institution, and there's some crossing in between those 2 places. And then care partners really emphasized wanting early provider guidance to make these decisions. So I'll share some of the thematic findings for our current care partners. They talked a lot about experiencing overwhelming uncertainty pertaining to future care setting decisions. They're earlier on in their disease, and they really want prognostic guidance to inform care setting decisions. So I'll share a quote that illustrates this. This current care partner said, "It's unclear. I mean, he's certainly not bad enough yet for placement. I don't know. See, that's the other thing. I don't know how bad somebody has to get. Somebody did say to me that when he doesn't recognize me, then maybe that's a time to do something. But he still does, you know, and I've got really good care at home." So this is a pretty typical response from someone who is caring for a person relatively early on in dementia. There's a lot of uncertainty, a lot of I don't know. Obviously, this is perfectly natural and expected when you're caring for someone earlier on in disease, but I think it really just highlights what people are experiencing as they think about these care setting transitions. I'll share another quote. This current care partner said, "It would probably be good for him to see a neurologist to maybe get a full physical to see how he's advancing. It would be kind of nice to know if there is such a thing as a stage, what stage we are at. That would be very helpful for me because, like I said, I'm trying to make some changes in our living arrangement." So what I like about this quote is that it really shows that link between prognosis and care setting very clearly. This person is saying, I want to know what stage of disease I'm at in order to make decisions about living arrangement. So this was a really key finding that we had where people are asking about life expectancy, disease stage, prognostic information. And they really saw that as being very integral to their decision about the living environment. Moving on to the former care partners and their thematic findings. So later on in the disease course, former care partners want resources from providers, and they really focused on specific recommendations for either a long-term care institution or resources to make home care possible. They're really focused on that explicit, actionable advice. So this former care partner said, I think the only thing I could imagine being better is if there was some sort of liaison team that helped people like myself who are needing to put their loved ones in a care facility. If there is some additional assistance that could be given, I think. And what would that additional assistance be? For lack of a better way of saying it, I think it's a bit more hand-holding. So this former care partner is really talking about how making this transition would have been aided by having a provider team who could really give them more advice and more actionable resources. Another quote, this former care partner said, "I told her doctor, enough is enough. I can't do this." And then we made a decision that the doctor had to come to the house. So this care partner is describing a situation that's a little bit uncommon in that the doctor was actually able to make house calls. And this is not something that's available to everyone, but I think it's a good illustration of the increased resources that are really needed to take care of a person with dementia at home, especially as they get to those later stages. So to finish up with some implications, care partners want a lot more support from healthcare providers in transition, but the guidance may change as people with dementia progress in disease. And I think this was one of the key findings from this study. That was something that we hadn't seen in the literature before, is that this guidance really does change and providers need to kind of take this into consideration as they counsel patients. So earlier on, care partners want prognostic guidance to inform care setting decisions, whereas later the guidance might involve specific facility recommendations or support to keep the person in the home. And the future direction for this work will really be to hone in on resources like guidelines and protocols that can help providers in navigating these conversations. We know that providers are not always very comfortable doing this, and so having more resources and really understanding the community where you and the patient exist is going to be helpful. If you can have some names of facilities that you know about in your back pocket or home care resources, that's really going to help these care partners. So just to finish up, I'd like to acknowledge the Hope Labs team, including my PI, Dr. Krista Harrison, who was a really fantastic mentor at UCSF, as well as Medina, her amazing staff person who helped me so much throughout this project, Dr. Marlon Mouse at UC Berkeley, who was a really great resource and mentor for me, as well as one of my funding sources, MSTAR, Claudia and Jyoti, my program advisors. And then on a personal note, I always like to acknowledge my grandma, who was my first love when it comes to all things geriatric and just the biggest inspiration for me to continue on this work. She knew that I was admitted to medical school, but she passed before I actually had started. So I think she'd be really excited to see the type of work we're doing. And then of course, my JMP family, friends, and my fiance and our 2 cat children. I don't think Mr. Pickles and Frankie are on this live stream, but if you are, I love you. And that is it. Thank you so much. Yes, Samir.
Thank you so much for this presentation. I was noticing that you included multiple different kinds of dementia and reflecting on how different causes of dementia can have different timelines and potentially different cognitive changes.
Yeah.
I was wondering how that affected your analysis of that.
So the question was about how different dementia syndromes would affect the analysis and kind of people's experiences. And I think that definitely did play a really big role. So I did not really focus on dementia syndrome as part of my analysis, but just through, anecdotally, I can share that reading about certain care partners' experiences dealing with certain types of dementia, for example, like frontotemporal dementia, which has a behavioral variant that can lead to really challenging behaviors for folks. Those care partners caring for a person with that type of dementia were experiencing very particular stressors compared to a person who might have Alzheimer's or vascular dementia. So it wasn't part of the analysis just because I think we didn't have super linked, because it was more qualitative, we really just wanted to elicit people's perspectives of the dementia caregiving journey more broadly. But I think it would be a good direction to go because certain types have really particular needs associated with them. Yeah.
Hey, Berkeley. One of my favorite palliative care physicians says, prognosticating is hard. And so he advocates for ranges. You have days to weeks, weeks to months, months to a year, something like that. Do you think that kind of that degree of certainty or uncertainty would suffice for some of the caregivers that providers that you interviewed or that were in the quotes you read?
So the question was about prognostication and whether having information about days to weeks or months to years is going to be useful for people. And I think it really depends based on the data that we saw. And I think there is some tension here because some people say that they want this prognostic information, but then there's also a subset of studies that will show you that actually this is really hard information to digest, and emotionally it's really hard for people to cope with, oh, you have exactly 3 years or you have this amount of time. So I think there's a lot of difficulty. I will say that there were a few care partners who said, like, I've gone online and seen that the life expectancy for someone newly diagnosed with dementia is 7 to 10 years. So I am planning to that level of specificity, like, okay, if I need to remodel my home, it's gonna take a year. So when should I do that? So I think people are very different. But I definitely, in my results, found that people wanted at least some information about, are you early? Are you late? About how long could you expect? But I think it's very tricky because people are, it's very emotional.
Thank you.
So I have the pleasure of introducing Jessica Hawkins. She is from Salt Lake City, Utah originally, and went to Washington University in St. Louis. Before coming to the JMP, she worked at a healthcare nonprofit that served Maya communities in Guatemala. Importantly, this is where she also adopted her dog child, Tortilla, so has a special place in all of our hearts. She also worked at UCSF in the Department of Pediatrics before coming to school. And I will say, on a personal note, and being her classmate, she's a huge inspiration, I think, to all of us. She's definitely someone that champions for things that matter to her, and she's never afraid to stand up for things that are really important to her. And to also just have a conversation and explain to you the why of how she thinks the way she does. I think she's trying to radicalize people here, and I think it's working, so I appreciate that. And just personally, I will say she's a really great and giving, loyal friend, and she has an encyclopedia-like knowledge of where to eat in the Bay Area. I'm sure she has dinner plans after this, so hit her up for recommendations, but without further ado, that's Jessica.
Which was my work around an ethnography of involuntary psychiatric holds in a public emergency department. So this presentation will discuss psychiatric detention, racism, and instances of physical violence towards patients and healthcare workers. So to give you a taste of what ethnography means, I wanted to start with reading some notes from one of my direct observations. So this was a 4-hour training. It was called Techniques for Effective Aggression Management. And the people who were there were ER nurses and technicians being trained by peers. This was a training required yearly, and I was there as a participant observer. For most of this class, we will learn to deal with the violent 5150s, explained the ER technician, indicating that patients under involuntary psychiatric holds, or 5150s, are the most likely to assault healthcare workers. The first part of the training covers statistics about assault, strategies to identify threatening behaviors, and de-escalation. For the final part of the training, he told us to find a partner. We were going to practice self-defense moves. We were learning how to protect ourselves from aggressive and violent patients, who he explained were often there because they were drunk, on substances, or had other behavioral health issues requiring 5150 holds. So including here 2 images from the training manual that we were given. When the trainer said we were going to practice the defense from a hand strike maneuver, a young Black woman nurse added, "Did you all hear I was punched 3 weeks ago? Room 19. He punched me in the jaw. He was small and frail. I didn't think he could do it because I'm big and strong. I don't like to use restraints on old, frail people." One of the other nurses interrupted to say that the local assistant DA is open to actively pressing charges against people that harm healthcare workers. The nurse then responded, "What am I going to do? Press charges on a demented person?" The trainer responded, "What's really important is to file the hospital safety report, because that's what's going to result in improved staffing." I moved to face my partner to practice the defense from a hand strike move. My feet were staggered, my knee slightly bent, the trainer guiding my stance. I put my hands in front of my face to block my partner's hand from hitting me. Then we switched and I pretended to hit the nurse. Next, we were introduced to escape from a rear choke maneuver. Due to the advanced nature of the maneuver, the trainer practiced with the nurse, who he mentioned also had advanced jujitsu training. The other nurse hooked her arm around the neck of the trainer, with the crook of her elbow tight under his chin. Oops, sorry. Meant to scroll down. He recommended that we push our hands under the attacker's elbow to give you enough air to scream for help. The trainer held the nurse's elbow, bending down on one knee as he wrenched the nurse's shoulder to the ground, flipping her onto her back. Another nurse mentioned, "I'm always surprised how well this works, even when you're so much smaller than the patient." So reflecting on this training, it was incredibly extreme. I was shocked, but I think it represents a really important aspect of how healthcare workers perceive their safety, especially in relationship to patients who are under these involuntary psychiatric holds. This training also brought up a lot of the themes that I'm going to cover today. The extent of fear of violence that nurses and ER technicians face on a daily basis, and structural issues such as understaffing and crowded patient rooms that contribute to this. One thing that was interesting that was left out of this training was discussion of how law enforcement might be involved in these situations. Okay, so what is a 5150? So this is the legal code that corresponds to the California law governing 5150s, or involuntary psychiatric holds. This is called the Lenterman-Petrashore Act. It was enacted in 1967. So notably, all US states have mechanisms for involuntary psychiatric detention. In California, this allows for up to a 72-hour involuntary hold for psychiatric evaluation. And the criteria for this are being a danger to yourself, a danger to others, or gravely disabled, all because of having an underlying psychiatric condition. So why are emergency departments important in the context of 5150s? So in most instances, people under 5150 holds have to go to an emergency department to get medical clearance. So emergency departments, which are already crowded, become a critical way station for psychiatric care. And this is all happening in the context of incredibly limited outpatient mental health care, decreases in psychiatric beds, and an increase in the number of involuntary holds that are occurring across the US. Also, there's an implementation of 988 crisis hotlines, which are meant to divert people from 911 calls into theoretically getting psychiatric care. And this kind of reflects wider movements to decriminalize mental health responses, which theoretically will put even more people into psychiatric care. So why did we do this study? With this increased importance of the ER and the provision of psychiatric care, I wanted to understand how does a public ER work as a frontline for managing psychiatric crisis, specifically focusing on structural features. And as I mentioned, there's a lot of work going into decriminalizing mental health with 988 hotlines and crisis response programs, like my colleague Paige mentioned. And we wanted to know more about how law enforcement was functioning to manage people under 5150s within the hospital setting. So I conducted my fieldwork, and I'm still conducting fieldwork at a public urban emergency department here in California, in a hospital that's relatively large with more than 200 beds. So far I have 25 hours of direct observation, so like the training I mentioned earlier, and I've conducted 11 interviews. I've focused so far on frontline staff. So these are nurses, emergency technicians, and registration workers. I've also interviewed 4 experts in the fields of psychiatry, law, emergency medicine, and people who are community activists. For my analysis, I'll just touch on briefly. I use an inductive approach, which allows themes to emerge from the data, and I analyzed my transcripts and observations with in vivo. And I used a critical approach, which really has an orientation towards structures and kind of attempts to wrestle with the fact that anthropology and ethnography in general has a really close relationship with a lot of oppressive structures. So another important aspect of ethnography is reflexivity, or thinking about how my values and my identities affect research design and analysis. So I'm a medical student. That was really important to get buy-in from a lot of the clinical staff. And I also think that my medical knowledge allowed for more of a structural critique without getting caught up in a lot of the minutiae of clinical protocols. My whiteness was incredibly important. It ensured buy-in from many of the white clinical staff and law enforcement, who often talk to me, I feel like, with a lot of openness. I also come from a history of working in a lot of abolitionist spaces. I believe that law enforcement has no place in society, let alone in medical spaces. And so I was really oriented towards looking for solutions while I was doing this field work. So first I want to go over what does the 5150 process look like within the place where I conducted field work. So first, police typically refer patients for a 5150. So they see someone on the street and they write a referral. Then the ambulance takes the people to the emergency department. As I mentioned before, they have to get a medical clearance. So once they get to the emergency department, they go through a process of stabilization. So when I say stabilization, I mean typically they're put in physical restraints and given chemical sedation. They're also given a series of tests, including a urine drug screen. Then patients are put into a very small room, which is called by staff members the 5150 room. So after that, patients can face kind of a few different trajectories. They can have their hold dropped if they don't meet criteria. They can be transferred to a psychiatric facility, or they can spend the rest of their hold within the hospital. So this photo kind of shows an example of what the trauma bay looks like, where the stabilization process happens. And it has more space, so there's more people who can kind of get involved and safely place restraints and administer sedatives, safe for the healthcare workers. The second image is a drawing from my observation notes of the room where people under 5150 hold are kept. So it's hard to overstate how cramped this room felt. It had 6 beds in it, and they're each separated by curtains, and the beds are no more than a couple feet away from each other. The ER technician has this desk in the middle, and that is to make sure it complies with staffing law requirements within the state of California that require for every 6 patients, 1 ER technician or nurse to be supervising. So one of my first questions was, what is the role of law enforcement? How are they present in this space? So in the ED, they're there 24/7 patrolling the hospital in general. They are county sheriff deputies, and this is a county hospital. Their sheriffs and police are also there accompanying patients who are in custody or incarcerated that need medical care, and there's also a private security force. So I wanted to share the perceptions of healthcare workers of the role of the hospital sheriffs that work within the hospital. So this is a quote from a nurse who has been working at this ED for over a decade. And she talked about how she perceives the role of the sheriff's deputies had changed during her time there. They're very hands-off because of everything that's happened in the media, everything with police use of force, anything that's gone bad and has been promoted. They're very, very hesitant to put hands on people. And I understand it, but it's also a little unnerving. It makes for a little bit scarier of a department. Another nurse shared about how this use of force policy affected her. The deputies can stand there and be a presence in the room, but they're not supposed to actually help you, which kind of defeats the purpose if I'm calling you because I need help with somebody being aggressive. I also talked to the sheriff's deputies around what they thought of this, their role. One deputy mentioned, this is a hospital with some of the most violence against healthcare workers. There's lots of it. You can't prevent it. It's just the clientele. When I asked him specifically what he thought about how he could prevent violence, he said, I know the medical staff have their own rules about what they can and can't do, but they take restraints off people who are just violent. There's no talking someone down who has hallucinations. So this is a really surprising finding for me. I feel like the sheriffs having a less overt use of force in the hospital is a result of this wider scrutiny and movements to limit police power within the community. I also thought it was relatively surprising that nurses, ER technicians, and deputies agreed that deputies are not effective in preventing violence against healthcare workers. So next I want to talk about how the shifting role of law enforcement has affected how healthcare workers interact with patients. So as I alluded to in the beginning, healthcare workers are turning to tools such as self-defense maneuvers as a response to violence.
But they also have the option of preventing violence, and they do this through things called behavioral restraints. So as you can see in this image on the right, behavioral restraints have two different components. One is the physical restraints, so these are hard plastic, where people are chained to the bed. They also have sedatives, which include antipsychotics, benzodiazepines, and ketamine. So these are things that are ordered every 4 hours by physicians, and healthcare workers often talked about these as the only way that they thought they could guarantee safety. So I wanted to read some quotes around how healthcare workers perceive their security role within the 5150 process. And I want you to think again of how small this room is where they're acting. This is the first place I've worked or I've had to frequently renew behavioral restraint orders. And I think that's more of a logistical thing. It's just the way this ER is built. There's just no way to have the required staffing monitoring these patients without having them in that room. Another nurse talked about how difficult it was to have to rely on restraints. Basically, the second anybody starts acting out or resisting, they get an order for medical sedation, and then restraints because we don't have a locked psychiatric area. That's what feels so shitty about being involved. I feel like in 5150s, we're literally restraining and sedating people. That's our answer to psychiatric crisis. So I argue that healthcare workers are essentially getting deputized to fulfill a security function in the setting of understaffing, and a shifting role of hospital law enforcement. And there's this really overwhelming perception that the only guarantee of physical safety is depending on restraints and sedation. And healthcare workers are experiencing a lot of moral injury. They feel really bad about having to resort to these tools within these contexts. So then I wanted to mention a little bit about things that have maybe been obvious to you in previous quotes, but I really want to emphasize how structural issues have created an environment not only for these types of coercive tools to be used, but has also created an environment that has invited racism and criminal stigma to justify or normalize these techniques. One physician mentioned, in terms of sedation and restraints, I think this hospital's psychiatric population requires more sedation, is slightly more unruly, but that's just by nature of it being a county hospital. Going unsaid here is that this hospital is embedded within a majority Black community. Another nurse reflected specifically on how she's noticed racism play out with restraint use. I think a lot of times it's the bigger males, especially the Black guys who come in and are cussing everybody out. They get restrained, sedated, and restraints until they leave most of the time. I've noticed that a lot with the Mexican patients too. So on a structural level, this 5150 process at the CD is set up to create conditions for things like restraints and self-defense maneuvers. It's also created an environment where racism and criminal stigma go unchecked. So, as I mentioned, deputies are not perceived to prevent violence against healthcare workers, and healthcare workers are in turn taking on the security function and facing a lot of moral injury in the process. And I argue that the 5150 process reproduces a lot of carceral systems that are justified by racism and criminal stigma. So, what do we do about this horrible situation? I think this is a big opportunity to involve healthcare workers in efforts to decriminalize mental health, specifically organized labor. I think there's a place for unions to advocate for safer work conditions that do not include law enforcement. I also think there's a specific urgency to invest in community care, things like housing, preventative healthcare, and peer-led responses to crisis. I want to thank my many mentors, Mark Fleming, my PI, who let me be in the driver's seat for a lot of this, and also had the patience to walk me through reading Foucault. Professor Obasagi, whose seminars were incredibly formative for me as a human and researcher, and my other PI, Dr. Harrison Alton, who is here today, a JMP alum, who was instrumental in guiding my understanding of ED's work in preventing feedback. My brother John is also here today, my loved ones Lauren and Camille, all of which supported me during this incredibly emotionally demanding work. I also want to shout out communities I'm a part of, including DPH Must Divest, my union, and the beautiful JMP that I love so much. I also wanted to directly speak to some of my faculty and lovingly call them in, as I've been taught to in the JMP. Notably, my PI has canceled class, in solidarity with us. And I think this is a really powerful message to send to the regions. And I also know that there is a letter going around for the School of Public Health faculty to sign on to show their solidarity, which I will share later in an email. Thank you.
So in your research while you were spending time talking to staff at the hospital, did you notice that there were any policy solutions that administrators were coming up with to decriminalize mental health and maintain safety for staff, or were people kind of just saying that this is how the system works, and there was like little suggestion on how to change it?
There was, so the question was, are hospital administrators suggesting solutions that work to decriminalize mental health? No. A lot of staff shared a lot of frustration with how the hospital in general didn't seem to care about their safety. A lot of frustration, especially with a supposed zero tolerance for violence policy. And I think that there, in general, were a lot of, I mean, it's hard to quantify, but in general, there are a lot of ideas of this is just how this is kind of the system we have to function within. Caroline?
I have a question. It seems like a really big part of your research is being in the space, and we've heard so much of the quotes from people that we were observing, and I'm just kind of curious what it was like to be in the space, and if there were differences in what you were seeing in terms of people's behavior and what their stance was.
Yeah, I think one obvious thing. Oh, question was things that I might have noticed during my observations that didn't necessarily come up in interviews. I think that law enforcement mainly, law enforcement was unwilling so far, has been unwilling to go on record with me and do recorded interviews. And so getting to observe how law enforcement functions within the space was really important. There were a lot of staff perceived them to fulfill an almost like social worker role, which I put in quotes because they're all armed. They have a gun, they have a taser, they have a baton. And I think that for me, it's hard to really conceptualize those interactions as like a social worker interaction. And I also think the camaraderie between a lot of staff and law enforcement was something that became a lot more obvious when I was in the space. For example, some of the staff members wear sheriff badge reels to indicate their support for the sheriffs.
Thank you.
Yes. So I promised David I would keep this short so he could spend more time on his beautiful presentation. So David was born and raised in Hawaii. He attended Brown University where he studied psychology. Also did a bunch of creative nonfiction writing and taught martial arts in Mandarin, which is incredible. Before coming to the JMP, he showed his dedication to queer people in many different ways. Also to people who use substances and those with HIV. He's worked as an HIV counselor, did research at Boston Children's, and later pursued a Fulbright scholarship in the Philippines. The JMP, I have loved getting to know David. We bonded over our love of drag, and I truly admire his skincare routine. I've never seen someone so devout about sunscreen application. David is also a talented poet and photographer. Notably was an incredible photographer at our JMP prom that we had. On a more serious note, David is deeply interested in the ways in which identity impacts health and has continued to explore this in his current project, the perceived barriers and facilitators to psychedelic-assisted psychotherapy among minoritized persons reporting psilocybin, magic mushroom use in the US. Implications for treatment and policy. Come on up, David.
Y'all are the real MVPs for sticking around.
Okay, let me just do some formatting things really quick because I cannot read the text at this size. Oh, dear God, it's small. Okay, awesome. So I'm just going to get started here. Oh, yeah.
Okay.
Oh, okay, thank you. So first off, why did I do this project? So over the years, I'm sure all of us, or maybe just me, have been bombarded with news about psychedelics and the excitement surrounding its use for mental health treatment, even for treatment-resistant mental illnesses like depression, for example, or treatment-resistant depression, rather, through this thing called psychedelic-assisted psychotherapy. As someone deeply interested in mental health, I find these developments really exciting. But I started to notice some concerns from researchers in the literature, which informed me of the many ways, or rather the many factors that may influence what people think about psychedelics and its use as a form of treatment. So first off, some background. What are psychedelics? Psychedelics are powerful substances that alter perception, mood, and thought. They include things like LSD or MDMA, otherwise known as ecstasy, or Molly, if you are Miley Cyrus. Ayahuasca, and notably psilocybin, which is the active ingredient in certain species of mushrooms. There's been a burgeoning amount of evidence suggesting that they may be effective in treating mental illnesses like depression, PTSD, addiction, end-of-life distress, with robust long-term improvements in mental health. Psilocybin is currently being tested as part of psychedelic-assisted psychotherapy in clinical trials. And moreover, a growing number of cities and states have decriminalized psilocybin, with Oregon and Colorado legalizing its use for therapeutic purposes. So what would using psychedelics like psilocybin look like in a therapeutic context? Although the exact structure and makeup of psychedelic-assisted psychotherapy, or PAP for short, can vary, in general, it will most likely be composed of 3 parts. First come the preparation sessions, whereby patients meet with especially licensed therapists before their psychedelic session to establish things like therapeutic rapport, share information about themselves and their history, and learn about what to expect. Moreover, the subjective effects of psychedelics are highly variable and are strongly influenced by factors that are addressed in these sessions. These factors are called set and setting. Set refers to internal conditions like mood, attitudes towards psychedelics and their therapist, motivations for using, their beliefs, their prior traumas. Setting refers to the environment in which psychedelics are being taken, what people see and hear, the people they're with. One of the primary determinants of setting is the relationship that one has with their therapist. So addressing set and setting is important not only for the effectiveness of treatment, but also to maximize safety by reducing quote unquote bad trips. There's also support afterwards, in which therapists provide emotional support and guidance during the trip. And lastly, there's integration, where therapists review patients' psychedelic experiences with them, and in some cases apply therapeutic techniques to reinforce aspects of their experience to foster sustained, desirable patterns in thought and behavior. So the main thing to keep in mind here is that, at least when it comes to Western medicine, this is a pretty different way of doing psychotherapy or talk therapy. Here, we're using a chemical substance to induce an experience that can have positive long-term effects on mental health, instead of, say, taking a daily medication to correct neurochemical imbalances in the brain. So here we have this exciting novel treatment. What are some concerns? What could possibly go wrong? So despite all of the hype, it turns out there is a growing concern regarding whether or how this radical treatment will be accessible to and accommodating for underserved populations, such as racially minoritized persons or Black, Indigenous, and people of color, or BIPOC for short. There's an abundance of evidence supporting these concerns, which mainly come from existing research on racial and ethnic disparities in mental health care, which are generally found in the rates and severity of mental illness and the accessibility and quality of treatment. For example, although the rates of depression among Black and Latino folks is lower compared to white persons, evidence suggests that when depression does occur, it's more likely to be more persistent and severe. Also, overall, BIPOC are less likely to receive mental health care, and when mental health care is accessed, BIPOC receive lower quality of care in general compared to white folks. Moreover, there is a racist history of drug policy and enforcement that disproportionately incarcerated Black and brown folks, as psychedelics are federally illegal and categorized as substances with a high potential for abuse despite lack of evidence for such categorization. This history may have encouraged white folks to experiment with psychedelics while penalizing use among BIPOC. Also, one's experience of race and the racial dynamics between patients and therapists may also impact set and setting for PAP. And also, BIPOC are consistently underrepresented in existing psychedelic research, calling into question whether or not their needs are actually being taken into account. And these concerns lead me to my current work. So to determine whether or how much factors like this may impact PAP uptake among BIPOC, I designed a qualitative study to interview folks to answer a number of interrelated and unexplored research questions. The findings that I will be sharing today will focus specifically on BIPOC's perceptions of PAP and the barriers and facilitators they believe would impact access for themselves and for folks in their community. A qualitative approach was used to help us delve into the complexities of the attitudes towards and the experiences of using psychedelics and mental health care as a minoritized person. We sought participants who are BIPOC adults residing in the US who report experience using psilocybin in mental health care. And I reached out to a number of psychedelic Facebook groups and Reddit forums, as well as Reddit forums and Craigslist ads situated in areas that have decriminalized psilocybin. I posted online flyers containing a link to a Qualtrics survey that let folks self-consent to participate, after which they took a survey to determine their eligibility. From that, a total of 738 folks completed the survey, of which 360 were deemed eligible at that point. However, after removing respondents located out of the US and who indicated use of a virtual private network, which allows folks from outside of the country to bypass Qualtrics exclusion criteria, a total of 144 respondents remained, of which 58 were contacted for interview scheduling, with 24 folks successfully completing online, audio-only, in-depth, semi-structured interviews on Zoom. Transcripts were automatically transcribed on Zoom AI and validated for accuracy. Thematic analysis was used as the framework for coding. 2 members of the research team discussed and developed codes found in the interviews to create a codebook and establish consensus. Coding was performed using Deduce. I also should note that to ensure maximum protection of confidentiality and potential repercussions from law enforcement due to use of a federally illegal substance, this project was also granted a certificate of confidentiality from the NIH. And I want to note that not everyone was happy that I was doing this work. And quite frankly, reactions such as these only serve to validate the aforementioned concerns. That was fun. And here are the results. Before I start, I'd like to take a moment to acknowledge my positionality. Although I share a number of identities with participants, I'm not privy to their unique experiences. I'm also not an active member of the online communities from which they were recruited or live where they are situated. And I want to acknowledge that my positionality has probably influenced this project and its findings to some extent. So who was interviewed? Ages ranged from 21 to 40 years old, with the majority of participants identifying their biological sex and gender identity as female. And a little under half of folks identified their sexual orientation as heterosexual, with a third of folks identifying as bisexual. And here are the racial and ethnic identities that folks self-identified as. I want to emphasize here that these are their self-described identities. We thankfully achieved a varied group of participants with a number of folks identifying as mixed race. Most folks expressed high levels of acceptability of PAP. However, there were several concerns regarding accessibility to this service, all of which I'll go through with examples using quotations that have been paraphrased for brevity and clarity. First, the level of trust with the psychedelic therapist. Folks expressed the need to be with a therapist with whom they feel comfortable and with whom they can trust having a psychedelic experience. Reasons for this need not only center on general comfort with in a therapeutic relationship, but also the potential ways in which lack of trust may impact the psychedelic experience and subsequently thwart its potential benefits. Some folks spoke of this concern in the context of how many preparation sessions it would take for them to feel comfortable around someone else. As one participant notes, for me personally, and I'm sure it's the case for many people of color as well, I just don't feel that physically comfortable around white folks. And I feel like those feelings would probably come to the surface during a psychedelic experience. If it did end up being a white person implementing, I would want there to be more time dedicated in the preparation part to talk about the possibility of, like, here's my racialized trauma, and here's what comes up for me when I'm in a room with a white person. And I would really prefer to know that this is a white person who is aware of what whiteness means and who is doing the kind of work to break down racism. Another interrelated perceived factor affecting PAP uptake reported by folks focused on the importance of identity concordance, having a shared identity between them and their PAP therapist. Concerns regarding this mainly focused on race and its potential impact on PAP. Many folks argued that this would be more important in PAP compared to regular mental health treatment, as one person notes. In my heart, I'm going to go, it's just as important, but I'm going to say more because you don't know where someone's going to go when they're having a trip, you know? As with all medical care, dear God, try to match people by race, because I feel like a large part of the depression and anxiety that a lot of people might be experiencing as Black Americans has to do with race and racism. And so I think having someone there that can relate to you during the trip is really fucking important. And even if people aren't recognizing that that's a part of their anxiety and depression, I bet, mushrooms will help with that. Most folks reported that stigma towards mental health treatment and psychedelics may impact PAP uptake. Some people noted how the combination of mental health treatment and psychedelics enhances pre-existing stigmas to negatively impact PAP uptake. One person frames this from a cultural perspective using his parents' beliefs as an example. Despite them having these engineering logic degrees, they're very much scared of ghosts or spirits or ancestors cursing them and making them kind of go crazy. In Chinese, it's called 神经病, which is like a catch-all for psychosis. And so I think there's a big fear of mind-altering substances and anything that alters the mind. I mean, I can already see how my own community's stigma towards multiple things, like the use of substances, but also accessing care itself, all of those things are already stigmatized at a very intense level. Most folks also reported concerns regarding whether or how much resources like time or cost would impair access to PAP, especially if folks don't have the luxury to take off work, as one participant notes. Yeah, definitely costs. Costs, and my other problem with psychedelic therapy is the amount of time you're going to have to spend in the clinic. Yeah, I don't know how appealing it's going to be for people. When you think of a person who's never dosed before and you tell them, I want you to come to my office and I want you to have a therapy session with this, using this medicine, but you're going to be here for 4 to 6 hours. That's a lot of time for the average American to be like, all right, let me take the day off from work. Lose money there. Lastly, many participants reported the need for more education and awareness about psychedelics and psychedelic treatment to promote PAP among BIPOC. Some folks highlighted the need for more accurate messaging regarding psychedelics to counter negative perceptions of them. And one participant referenced his experience in having to educate others about psilocybin to dispel misconceptions about it. You have to reach out to us. You got to put it in our face. I don't know, it was kind of rare that I came across it. For one, we're not going to look into nothing that we know nothing about. Black people don't do shrooms, in my opinion. You just have to educate us, because I educated a few people who thought it was the worst thing ever. Another participant emphasized the need for PAP treatment facilities and organizations to demonstrate a reparative commitment to undo the harms of drug criminalization on marginalized communities, and to promote awareness of the indigenous history of psychedelics in order to be appealing to BIPOC. She references her concern by using her understanding of what happened with marijuana legalization. A big element would be you're not benefiting from legalization when there's still people suffering from an era of criminalization. I think sometimes I feel there's so many new companies that are emerging that are promoting some aspect of psychedelics, and they feel separated from the history of how people who use psychedelics have been treated in the US. It just feels disingenuous, right? In my head, the analogy to it is sometimes you walk into a legal dispensary, and you see all these corporate ads for marijuana, and that the state is benefiting from the taxes that they're putting on this product, but none of that money is actually going to help people who were previously harmed. It feels disingenuous. It feels disconnected. It doesn't feel like a comprehensive and accepting space. So what can we conclude from these findings? Surprise, PAP is not exempt from the barriers that already exist in mental health care, but there are factors unique to this treatment that add to or emphasize these existing barriers. And there are unique needs among BIPOC that should be taken into account. Trust and identity concordance between patients and PAP therapists were thought to be considerably more important compared to regular mental health treatment. Notably, folks expressed the need to be able to establish rapport with the PAP therapist, which was reportedly contingent on the amount of time spent with them and their shared identities. This may be problematic for BIPOC intending to access PAP in Oregon, given the state may potentially be providing only one preparation session for PAP when treatment starts in January. This also underscores continued efforts to diversify mental health professionals and promote cultural humility and anti-racism training, as these factors may very well negatively impact set and setting, which could potentially affect the effectiveness of PAP for BIPOC. Moreover, the stigma towards mental health treatment and psychedelics in combination may hinder BIPOC from accessing PAP. Responses lend support to the purported harms the history of drug criminalization has had on BIPOC's perception towards psychedelics, And there are also culture-specific conceptualizations of mental health and mind-altering substances that may also play a role here as well. Given that PAP is still largely unavailable, we are in an opportune moment to collaborate with communities now to devise best practices for PAP outreach and education and dissemination to address stigma against mental health, treatment, and psychedelics. Furthermore, in addition to concerns regarding cost and insurance, the distinguishing feature of PAP, the psychedelic trip, may add a logistical burden among BIPOC, as the trip can last anywhere from 3 to 6 hours. Moreover, the potential financial costs for PAP, both for prescription psilocybin and for psychotherapy services, may be prohibitive. There currently isn't a reference for estimating what the cost will be like, but cost for treatments with ketamine using psychotherapy are about $400 to $500 per hour. And psychotherapy outside of the US at certain retreats could cost someone up to $10,000. So it's imperative to determine ways to reduce costs and make PAP more accessible. Lastly, responses from participants noted the importance of more education, outreach, and activism to increase PAP uptake among BIPOC. It would be ideal for organizations to use a reparative approach to reduce stigma towards psychedelics and positively impact PAP uptake. Making demonstrable, explicit commitments to increasing awareness and undoing the harms of racism's impact on drug criminalization and attitudes towards psychedelics, as well as issues regarding Western medicine's appropriation of psychedelic plants and substances from indigenous communities from which it originated, may empower communities to promote equity in PAP. And this concludes my presentation. I want to take a moment to thank the JMP, everyone here, and then some, especially these 4 folks. Susan Ivey is like literally the embodiment of "you take the wheel," which has given me the flexibility to pursue this work and the agency to do that. And Dena, who's an incredible undergraduate referred to me by Mayor, who is co-coding the process, and Dr. Zamaria at UCSF, and newly working at the Berkeley Center for the Science of Psychedelics, and my dear friend Aisha Chaudhry, who made sure that I did not lose my shit during this process. Go for it.
Yeah, so thinking about how exclusionary a lot of these psychedelic research studies have been, and also reflecting on the level of intention that's necessary to make
The level of what, I'm sorry?
The level of attention that is necessary to make psychedelic use in a psychotherapy setting feel safe. Do you feel like it's ethical to be testing psilocybins in research settings, considering I think some of that intention probably doesn't exist in like a clinical study, and how some of your findings can be applied to psychedelic use in a research setting?
So the question was, oh my God, that was a lot. Whether or not it's ethical to apply some of these findings to psychedelic research
Yeah,
studies?
just in general to test psychedelic use.
To test psychedelic use among anyone, or BIPOC specifically?
And how to do so ethically.
How to do so ethically? I think that's a very interesting question. I think there's some incredible work done by Dr. Monica Williams, who literally kind of revamped a clinical trial site to make the research process more appealing to recruit people of color in the local area, implementing changes at multiple levels, down to the diversity of the PIs and the therapists, and implementing 8-week cultural community trainings, and even making sure that the language in the flyers were accommodating to dispel history and the potential medical mistrust that is still existing in a lot of communities. So I'm not entirely sure if I can speak to the ethical, whether or not that is ethical, because there are examples of work that has really gone into trying to resolve the issue of underrepresentation in clinical trials. And at the same time, I understand that there is hesitancy there to want to take part in an institution that has a history of mistreatment. So I'm afraid I can't answer your question, but this is an important issue for a lot of folks, and there's a lot of work being done around it.
Thank you, David. All right, this was our last presenter. So just a few closing. Oh. Thank you. You're supposed to do this. Well, I just want to thank all the presenters. What beautiful work you've shared with us today. I think we all, as faculty, share our pride in all that you had to show to represent these 2.5 years of hard work for your masters. I want to thank very especially Seth Marvin. Always shows up. I mean, Jody brings the best in everything, including Seth. Well, next, I would like to very specially thank Deneen, who has been here behind in the organization, making all of this happen as if, everything was, and it was perfectly planned, but it was perfectly executed. So thank you, Deneen, and I want you to come here for just to receive a small token of our appreciation.
Everyone so much. I'm overwhelmed. Thank you so much.
And now I'll leave the microphone to Jyoti.
Great.
Thank you, Master.
Congratulations, you made it! So awesome. I'm so inspired and so jazzed, and I thought I'd be exhausted at the end of this day, and every single talk lifted me up. So thank you so much. Congratulations to all of our JMP3s, to your families, to the mentors, to everyone who made this day possible. But wait till what I say next. So I also wanted just to give a couple of thank yous. I want to thank our student volunteers. We had a number of student volunteers who helped us through and so thank you so much for that. I also want to thank Seth for doing the live stream. He not only live streamed, but then was like posting on Facebook and Instagram, and I was like, what is happening here? Seth is paid in Blue Bottle coffee, but I think the priceless gift is that I will stop asking him about the live streams. I also want to add my thanks to Deneen. Deneen is amazing. So when all the rest of us are like this balloon, Deneen is these balloons. She brings such an incredible energy and joy to everything you do, Deneen. And I think in this time where we're thinking about graduation and symposium and all these things that are swirling around us, you just are like so joyful and so positive, and the energy you bring really does lift up. You are the helium in our balloons. I also want to say, when we were talking about planning the symposium, Deneen was like, I don't see what the big deal is. It's amazing students talking and there's some food. It'll be fine. And we were like, yeah, it'll be fine. And see, it was fine. So thank you, Deneen. And we have a small gift to present to you also. And then the final person I want to thank is our very own Gustavo. None of us would be here without Gustavo, his infectious energy, his smile, his can-do attitude, and most of all, just his heart and his kindness. Whenever I see Gustavo, I'm like, it's gonna be okay. Like, we're gonna get through this together. And I think the energy you put into this symposium and just getting all the details nailed and working with the students and just helping to make today happen, really, we just wouldn't be here without you. So thank you so much, Gustavo. All right, and then I think that really is the end. Oh, we're gonna do a photo. So JMP3, we're gonna do a photo, your post-symposium photo. So maybe we can do that outside where the light is a little bit better. And Mary, come Absolutely. So why don't we do this? Why don't we go ahead and do a quick bio break and then meet outside? And I'm getting the red card, so that means I have to stop talking. So meet outside, we'll do a photo, and then go celebrate. Thanks, everyone.